Good morning, good afternoon, good evening to friends and colleagues throughout the world. We would like to welcome everyone to our Innovate Retina program. And today we have a great pleasure to focus it on ocular inflammation. As all of us have known, ocular inflammation has become, unfortunately, a concept that we have had to deal with during the past several years through various ophthalmic indications. Many of us who are working on the field of ocular inflammation and uveitis have been managing this matter for decades. However, for many of our young colleagues, many people who have not dealt with inflammation before, it has become a major factor. Therefore, we'd like to devote today's session and to learn more about what we can do, how do we understand it, and how we can advance this in order to manage our patients better. Thus, we thank you everyone for joining us. Certainly, we would like to thank the organizer for this program. These are my colleagues at the Bayer Institute at Stanford University, Dr. Preeti Mutanjaya, who had the ocular oncology unit at Bayer Institute at Stanford, Dr. Diana Do, who's our vice chair for academic affairs as well as clinical research there. And then Dr. Stephen Smith, one of our faculty member in the retina division at the Bayer Institute. During the past year or so, all of us have been working very hard to be able to put together the program for you today. And I certainly would like to thank all of them for all of their effort. In addition, this program and today's session would not be possible without the contribution from our faculties in the United States and throughout different continents around the world. And we'd like to thank all of them. As you will see through the program, their expertise will allow us to understand more about what ocular inflammation is and how we may be able to manage it and move forward with it. The agenda I've listed here, there will be 4 different sessions of today's program. Session 1 on ocular inflammation, Session 2 on therapy and development, Session 3 on managing inflammatory macular edema. We would then have a break with some of our sponsor presentation, and then we will finish with Session 4 in innovation for pharmaceutical company. Today, learning objectives are listed here, and you can also view them on the website for us for the program as well. Our activity today is jointly provided by Clinical and Patient Educator Association and iVista Medical Education, and we certainly would like to thank them for their partnership for our program. As all of us know, no meeting can exist without the support of our partner and our industry sponsor. And we sincerely thank them for their support and for their encouragement and for their partnership throughout the year with Innovate Retina. Please note that during the break, you will have the option to view a non-CE sponsored video presentation or take a brief break. Throughout the day, throughout the program here, you definitely will have questions, and please use the question and answer icon to answer your question, and then we will try to address as many of them as possible. At the conclusion of the program, you will receive instruction on how to obtain your CME credit, and you can access it also via the QR code that are listed here. Today, we begin our first program for Innovate Retina at the live virtual program on ocular inflammation. Please also plan to join us live at the American Academy of Ophthalmology. Our program will be on Thursday, November 2nd at the St. Regis Hotel in San Francisco. And now let us start with the first session. The first session today will be moderated by Dr. Diana Do from the Bayer Institute, as well from Dr. Ashish Sharma, who is the consultant in retina and head of research at the Lotus Eye Hospital in Coimbatore, India. And Ashish has done outstanding work throughout the year, focused on different parts, especially on inflammation that related to retinal diseases. With that, Diana and Ashish, please take over and start our day. Thank you.
Thank you, John. Great to join everyone today on our first session on ocular inflammation. It's my pleasure to introduce Dr. Paul Yang, Associate Professor at the Casey Eye Institute at Oregon Health Sciences. He will provide an update on inflammatory concerns in vector and gene therapy. Paul?
Thank you for inviting me. I'll be talking today about gene therapy associated uveitis. These are my disclosures. This will be a very brief overview of immune deviation, immune response to AAV, immunology of retinal degenerations, and finally gene therapy associated uveitis. So immune privilege in the eye is not a novel concept, but it's probably better described as immune deviation rather than privilege. Anterior chamber associated immune deviation, or ACADE, has long been known to be an active process wherein APCs from the eye in concert with the thymus and spleen create a form of immune deviation that inhibits type 1 delayed hypersensitivity, Th1 response, and complement antibody response. And rather, it favors antigen-specific cytotoxic T cell response and antigen-specific T regulatory cells and antibodies. Now, the subretinal space is also now known to be a site of immune deviation with very similar overlapping properties with ACADE, and also favors the Th2 response. In addition, macrophages, the APCs in this space, also include innate microglia and RPE cells. The RPE cells play an active role by inducing Treg, disarming and eliminating active T cells, and secretion of anti-inflammatory cytokines such as TGF-beta. Much less is known about the intravitreal space on whether or not it harbors any immune deviation. The immune response with gene therapy begins with the innate immune system, which recognizes structurally conserved molecular patterns. When you think about inflammation after gene therapy, the trauma of the surgical procedure can release immunogenic debris, also called damage-associated molecular patterns, or DAMP. With regard to the vector, the pathogen-associated molecular patterns, or PAMP, are the capsid and the CBG motifs in the viral genome and transgene. Other possibilities are the transgene RNA and protein, especially if the transgene does not exist in the human proteome. Obviously, impurities can be immunogenic as well, but hopefully that's the least of our worries in clinical trials. So the immune response to AAV begins with toll-like receptors, or TLRs, which play a key role in the innate immune system. TLRs are expressed on the surface of APCs, such as macrophages, and different TLRs recognize the viral capsid and genome, which lead to expression of pro-inflammatory cytokines and interferon. There are also pattern recognition receptors, PRRs, that recognize viral genome and transgene RNA. As we all know, cytokines can potentiate inflammation, immune cell recruitment, or cause direct damage via TNF-alpha or triggering of reactive oxygen species. Cytokines and interferon can promote APCs, B cells, and T cells to trigger an adaptive immune response to form antigen-specific T cells and antibodies. The following is a schematic of an innate immune response to photoreceptor degeneration and AAV. As photoreceptors degenerate, damage-associated molecular patterns, DAMPs, are liberated, and phosphatidylserine is expressed on stressed photoreceptors, which likely act in concert to trigger resident microglial activation and macrophage infiltration. These DAMPs can be composed of a number of small molecules. The innate immune system is modulated by intracellular signaling that involves microglia, macrophages, Mueller cells, RPE, and photoreceptors. Neuroprotective factors include chemokine fractalin, TGF-beta, IL-10, GDNF, and leukemia inhibitory factor. Pro-inflammatory factors include interleukin-1, 6, TNF-alpha, and nitric oxide. And then you introduce gene therapy, typically as a subretinal injection. The pattern recognition receptors for DAMPs and AAVs include toll-like receptors and nucleotide binding oligomerization domain-like receptor, or NLRs. Microglia also express receptors for interleukin-1 and the chemokine fractalin. Myeloid differentiating factor 88, or MyD88, is an important adapter molecule for the TLR and IL-1 pathways. All of these pathways compete for a net response that can activate microglia to express TNF-alpha, nitric oxide, which are cytotoxic, as well as IL-1, IL-6, and interferon, which can promote an adaptive immune response. Ultimately, microglia and macrophages are dual role effectors and effectors, capable of pro-inflammatory M1 phenotype that is detrimental degeneration, and an M2 phenotype that is neuroprotective. So these are the characteristics that we have observed of gene therapy associated uveitis in clinical trials. We define it very broadly as any clinically observed intraocular inflammation greater than expected from the surgical procedure alone in terms of severity, location, and duration. The location of the inflammation can be anterior, intermediate, posterior, or panuveitis. The duration can be a single limited episode after gene therapy, but it can also become chronic or recurrent. There's also an emerging concept of immune-mediated retinal damage with minimal or no clinical signs of inflammation. This has been observed in non-human primates, and we are also now observing it potentially in Luxturna, where we see perifoveal retinal atrophy in about 25% of cases. These are the risk factors for GTU. The top two factors are high viral genome dose and high capsid dose, which act synergistically to trigger and enhance inflammation. Across different trials, there appears to be a dose response with a threshold between 10 to the 10 and 10 to the 11 VGs per eye. We theorize that exposure to the ciliary body is inflammatory, as we've seen more intermediate uveitis associated with intravitreal injections or significant reflux from subretinal injection. The choriocapillaris is not known to be a space of immune deviation, so any penetration unintentionally of Brooks can be immunogenic. More data is needed, but recent studies in X-linked retinoschisis by Dr. Sieving, Sen, and colleagues suggest that there may be a pro-inflammatory phenotype that predisposes patients to GTU. So far, pre-existing antibody titers, or AAV capsid, pre-existing antibody titers to AAV capsid or transgene protein does not seem to be consistently correlated with inflammation. So these are the consequences. In retinal degeneration, there is already evidence of secondary immune-mediated damage to the retina, and that there may be a pro-inflammatory state. While the goal of gene therapy is to stop degeneration and prevent vision loss, the risks of inflammation may act synergistically with these potential pro-inflammatory states to cause GTU. Not only does GTU exacerbate secondary immune-mediated damage, but it undermines safety in clinical trials and blunts the biological signal, making it more difficult to meet efficacy endpoints. Treatment. Although it's already very common to employ perioperative, oral, topical, and sub-T non-corticosteroids, there is no standard for long-term treatment of GTU should it be necessary. While the considerations for steroid-sparing immunomodulation are similar to our uveitis practices, there are additional considerations for not treating aggressively, and that is exacerbation of retinal degeneration, failure to meet endpoints, and permanent loss of gene therapy benefits. So in summary, I've discussed immune deviation in the eye, why it might be a good place for gene therapy. and also discuss the immune response to AAV. We also discussed the clinical definition and risks of GTU. So here are some references for the talk and for further reading. And just want to thank all my colleagues and the team that make our work possible. Thank you.
Thank you, Paul. I'd like to introduce my co-moderator this time, Dr. Ashish Sharma, who will then go on to our next speaker. Thank you.
Thank you, Diana, and thank you, Paul, for such a wonderful talk. And now I would like to invite Dr. David Boyer, who is going to talk about the complement, which is another a very important aspect that the cutting edge therapy that we are hearing about. So over to you, Dr. David Boyer.
Thank you very much, and thank you very much for the organizers allowing me to be here today. These are my financial disclosures. And in addition, I have an additional disclosure. I'm not a uveitis specialist nor a neuro-ophthalmologist, but I've known to cause a fair amount of intraocular inflammation. So the first thing I want to discuss is what vector is used in these trials, AAV2 versus AAV8. And it's interesting, about 70% of the normal population has pre-existing antibodies against AAV2, whereas only 30 to 38% of patients have antibodies against AAV8. Now, why is that important? Well, the presence of antiviral antibodies has been correlated with decreased gene expression. Therefore, AAV8-based vector therapy has the potential to be a little bit more effective than AAV2. NAbs are not associated, however, with increased inflammation, but they are associated with reduction in efficacy. And here, if you look at the protein levels that were in the RGX-314 trial, if you divide them between patients who had high NAbs and low NAbs, the patients with the low NAbs had much higher expression of the RGX protein levels. As Dr. Yang brilliantly pointed out, intraocular inflammation has been associated with almost all intraocular gene therapy. And what really changes the amount and type of inflammation is the route of administration, as was described. We have intravitreal, suprachoroidal, or subretinal, and each has a positive and negative effect associated with it. Intravitreal seems to cause the greatest degree of inflammation, as was pointed out. You get humoral response and antibody production at a greater level than the subretinal. And you get better sustained outer retinal transduction when you use the subretinal route. The vectors that cause the inflammation, as was pointed out, are usually the capsid, the viral amount, or even the transgene. And empty capsids induce vitreal inflammation at a lower level than full capsids, implying that capsids alone can cause this vitreal inflammation. But the amount of virus, as was pointed out earlier, is extremely important. And the higher the viral load, the more chance you have of developing significant inflammation. And here in this little cartoon, you can see the capsids or the transgene, or actually even the target response. So what triggers the inflammatory response? As was pointed out, the host immune response are typically directed against microbial pathogens such as AAV. However, they can recognize transgene products as foreign. So any foreign particle that's put into the eye, either subretinally, suprachoroidally, or intravitreally, will elicit some degree of immune response. Additionally, immune response can be triggered not only by the viral capsids or transgene, but also by the viral genome or the transgene itself. So the inflammation will vary depending on how many capsids are put in, where you're putting it in, the route of administration, biodistribution, and the promoter and transgene. So the timing of inflammation, in my experience, we've seen very early inflammation, and this appears to be secondary to immune cells, including the dendritic cells, microglia, macrophages, Dr. Paul Yang described, using pattern recognition as toll-like receptors and immune responses. It's therefore seen within hours or days. So markedly early response. And subsequently, the anti-capsid adaptive immune response by B and T cells develops days to weeks after the AAV vector is administered. So be aware of late inflammation. So when you start to taper, and we'll talk about that in a minute, taper your steroids, many times you'll see a little flare up because you haven't significantly or reduced or dampened the response, or you actually have an additional response from the T cells and B cells. So we discussed, or Dr. Yang discussed, the adaptive host immune response that contributes. It's mediated by T cells. The capsid protein transgenes interacts with the naive T cells, and then they differentiate into antigen-specific T cells, including CD4 plus helper T cells, and interact with B cells and generate a humoral response. And CD8 and cytotoxic T cells mediate the cellular immune response. Steroids, as was pointed out, are the backbone of our treatment, and the route of administration has been topical. In some studies, subtenons, and others intravitreal, even oral in some studies. It's very, very important to start the treatment early, and don't stop treatment until all inflammation is resolved, as this may just be suppressing a low-grade inflammation, and by stopping early, you may end up with a rebound. So flare to me equals inflammation. It's a breakdown of the blood retinal barrier. If you see flare, continue treatment. OCT cells, we now know from BioView and other studies that we can look at our OCTs and actually see inflammation. Iris atrophy is one of the other things to look at. The biggest question is, how long is treatment needed? So I recommend we start topical therapy 1 week before treatment, and that we decrease it 1 week before you see the patient. So if you have the patient on 4 times a day for 2 weeks or 3 weeks or 4 weeks, whatever, 1 week prior to coming in, you can reduce it. And the reason is that in typical treatments, what we would do is we'd start treatment, treat them for 4 weeks, and then go to 3 weeks, 3 times a day. And that we would have almost a month period sometimes where we wouldn't be seeing the patient. By reducing it by 1 week before, you at least can see if there's a flare up or if you have to go back to an increased dose. There are future treatments, as was pointed out, targeted blockade of specific cytokines, as interleukin 1, 6, T cells and B cells, and macrophages are extremely important. And mycophenolate was used in the Infinity trial. I'm not sure that monoclonal antibodies are necessary at this point. So I was also asked to speak about the ischemic optic neuropathy. And as everybody knows, in the Pellis group, there were 7 subjects in the monthly and 1 subject in the every other month, and none in the sham group. All subjects who had ischemic optic neuropathy had ocular systemic comorbidities, according to the sponsor. Of the 8 cases, 3 were classified as severe, 3 were moderate, and 2 were mild. So 5 of the 8 patients continued in the study. So only 3 patients discontinued the study, and those were all in the severe category. 4 out of 8 of the patients who had this actually enrolled into the extension study, and 1 out of 8 completed the 24-month study only and did not go on to the extension Gale study. All subjects in the severe group were older. The median age was 83. 2 of the severe SAEs were associated with significant vision loss, and the patients discontinued treatment. Both were reported by the investigator to have had evidence of high blood pressure close to the event. Moderate SAE was not associated with vision loss, and the patient missed 1 dose before resuming treatment. And none of the SAEs were reported to be associated with interocular inflammation. None of the SAEs were associated with significant vision loss, except for the severe. All patients, according to Pellis, demonstrated risk factors, including hypertension, hyperlipidemia, diabetes, and obstructive sleep apnea. All had disc structures considered disc at risk, and they define that as a 0.2 disc cup disc ratio. The onset was variable between 7 months and 23 months, and based on the timing, all the events occurred approximately 2 weeks or longer after last injection. There did not appear to be a relationship to intraocular pressure. So is this a real effect, or was this bad luck for Pellis? Well, the mechanism's unknown, but it appears in the Iveric data that they've had two cases now, and one in their first cohort, the Gather 1, and now in the second cohort. And when you calculate out the number of patients involved in each trial, you find that there is definitely a statistically significant difference. When the Medicare beneficiary is over the age of 68, the incidence is 0.082%. And when you look at the monthly in Apellis, it approached 1.67 and 1.2 on the Iveric, though I don't have the number of injections, so it's a little difficult to come up with exact numbers. But based upon the fact that they've had 2 in the Iveric, 8 in the Apellis, and the size of the trials, this appears to be real, though I honestly don't know the mechanism. So lessons learned, I think if you get a baseline of the optic nerve before beginning any of these treatments, and if you have a small cup disc ratio, consider treatment every 8 weeks, which reduce significantly the incidence, or avoid treatment altogether. Thank you very much for your attention.
Great. Thank you so much, David. Always an educational talk. Now we're going to go to our panel discussion. I also want to introduce one of our faculty members, Dr. Puya Dayani, who's a faculty member at the Retina Vitreous Associates Medical Group in Los Angeles. He's both a retina surgeon and uveitis expert, and he'll be giving us insights as well. So let's encourage all of our virtual attendees. If you have a question, just click on the Q&A icon on your Zoom screen, and you can type in your question, and we'll make sure our faculty speakers address it. Maybe Ashish, I'll let you start with the first question.
Yes, Paul, I mean, your talk was very interesting, and probably, what we could gather from the talk is that predominantly the primary driver of the gene therapy is mediated by, viral delivery of the vehicle. So, Stephen is asking that, whether we have something like non-viral delivery, like nanoparticles or plasmid DNA, which could get rid of, this kind of complication?
That's a good question. So yeah, I think, as we are seeing inflammation now in AAV, associated gene delivery, I think we are thinking about the alternatives, right, for the future, nanoparticle and plasmid transduction, as you've mentioned. So yeah, those are promising therapies. I think currently AAV is still, more efficient. But I think these other alternatives are, I think, improving. It's also important to remember that, the DNA itself is, it can be inflammatory. So even having, naked, DNA being a byproduct that's not within nanoparticles, or, any kind of incomplete DNA particles itself can be inflammatory as well. So there'll probably always be some level of immune response to gene therapy, but yeah, you can modulate it if you have, alternative ways to deliver it.
I know that David had talked about treating patients with, say, topical therapy to control some of their inflammation. Puya, I wanted to get your insights. If you were to use topical therapy, what topical steroid would be for you?
David and I have shared some of these patients that we've seen that have had this more prolonged inflammation, and some have been more moderately aggressive. We've usually used Durezol, difluprednate, and seen really quick response, like very rapid response and resolution, and then just very gradual taper. They do tend to recur, and so in some of the patients we've had an extended period of maintenance therapy. I don't know that we know if there is a specific regimen that's best, but we definitely found a very rapid response with difluprednate.
But Paul, do you see the IOP fluctuations more with the difluprednate?
Certainly, just like you would with anyone else. Again, the number of patients that I saw with this was not large enough to know if they behave differently than a typical uveitis patients. But in the patients that we did treat, we did not have any IOP issues, but it's a known side effect. So I think that's something that you monitor, and you're monitoring these patients pretty regularly anyways, because you're watching them for, let's say, the exudative process or DME or whatever it is. So they're in there pretty regularly.
David, when would you consider systemic therapy? I know a lot of us would be comfortable first using topical, but then if the vitreous inflammation persists, when do you use oral prednisone?
It obviously it depends on the age group. When we're dealing with the elderly, I really don't like to put those patients on systemic steroids for any length of time. I think, especially in the COVID era, patients really would have not wanted to be on steroids at all for the reduced immune for their entire body and the possibility of getting worse. So I know that a lot of companies do it, and certain companies are testing whether it's necessary. I think that, as Puya pointed out, I think topical Durezol may be administered, 4 to 6 times a day, can get you levels high enough in the vitreous that you don't need systemic steroids. But a short-term course, I can't argue. There also have been people that have wanted to use Ozurdex because it gives you an anti-inflammatory response. That's being tested. And subtenons, for the patients that are receiving suprachoroidal, subtenons in that area would seem to be very logical, because the reaction is usually just more of an episcleritis, not a huge inflammation in the eye itself. But certainly short-term courses are not a problem, but these are elderly people with osteoporosis, and putting them on systemic steroids, I'm not a big fan.
So I have a question to all our panelists, that in case you see the anterior segment inflammation or vitritis, do you go for further testing just to check whether vasculitis is there or not there?
Well, yeah, I think it's appropriate to assess the severity and the locations, right, of all of the inflammation, as I kind of introduced in the way we think about it. It can really be anywhere in the eye, and just because you see cells in one part doesn't mean you're not missing something in the posterior segment. So I think you should do a full workup with diagnostic imaging to make sure you're not missing anything. Is it a panuveitis? So I think you should definitely be comprehensive in your assessment of the eye. And as far as steroid treatments, I think that that will dictate what kind of choices you make. Personally, I think because immune deviation, and hopefully when you treat with steroids or immunomodulators, you're trying to get the eye back to a state of immune deviation, because it's governed not just by local but systemic immune system. I do favor some level of systemic steroid coverage, at least initially. But I agree, it depends on the patient, and especially in elderly patients, you have to really watch how long you keep them on oral steroids.
Boy, what kind of investigations you go for, like wide field angio in all these cases?
Ashish, that's a great question. I think that we've seen in the wide field angiograms evidence of some degree of vasculitis in the periphery in some of these patients that really you didn't see anything in the posterior pole. It's not vaso-occlusive necessarily, but certainly you're correct in these patients if they are developing inflammation, Dr. Yang's correct. Depending on the degree of inflammation, we'll certainly modulate what we treat the patients with. But yeah, I do wide field angiography in patients who are developing some degree of inflammation, see how widespread it is.
And since it depends on which disease we're dealing with, but in some inherited retinal degenerations, it may be good to get a baseline, because there are some entities like retinitis pigmentosa where they actually look like that they already have some level of retinal venous leakage, even at baseline. And we're not exactly sure what causes that, whether that's true inflammation or just part of the degenerative process.
Oh yeah, I had a question for you. You know, we're talking about inflammation with these vector-based therapies, and there are a lot of non-vector-based therapies that are looking for longer duration. Let's say high dose of aflibercept. We have faricimab available. As a retina surgeon specialist, do you favor something that's in office that has longer durability, that you don't have to worry about this potential risk for inflammation? Or would you still be offering your patients vector-based therapy when it becomes available?
It's an awesome question. And this is, I think, something that we all have to figure out. It definitely depends on treatment burden. You know, some people are so easy to extend, and then you might have less incentive to try something that might have additional risk factors. And there's some people that are so treatment resistant and compliance and all these other factors where you might be willing to take a little bit more of a chance with potential side effects. I think it's going to be very individual and sort of what side effect profiles we see, but it'll be great to have the choices and to find something that matches each of the patient's needs and limitations.
Shamish, my question to all
We
the
also had a
panelists.
question from, yes. Go ahead,
Shamish,
Ashish.
what could be the areas, or what would be the time when you take a decision of surgical intervention in these cases? What kind of inflammation that you would incline for the surgical intervention?
Well, I think if you have very severe 3 to 4 plus, Sun criteria level of inflammation, and anything approaching panuveitis and endophthalmitis, I think you have to basically debulk or reduce the antigen load. Those I think would be the obvious cases, right? Like, very severe, rapid, within 24, 48 hours, hypopyon panuveitis.
I think that's a good example. Certainly in that case, you're also thinking, infectious endophthalmitis possibly. So in that situation, that may also steer you in first, maybe doing a tap and inject. Each person, I think, has their own style with how early they go in for presumed or suspicion of infectious endophthalmitis. So I generally am slower to jump in for vitrectomy if it's just to get rid of inflammatory mediators. I usually will try to calm the eye otherwise, and then maybe do that depending on, because some people clear pretty quickly. And so again, I think that for me, that's more of a long-term decision, not so early on.
We have a question from the virtual audience. This is for Dr. Boyer regarding the ischemic optic neuropathy. Is there a treatment that could be offered to patients who develop ischemic optic neuropathy, and when is the ideal window for treating these patients?
I don't know of anything that will really treat ischemic optic neuropathy. I mean, certainly you need to rule out the possibility that this is temporal arteritis, or it's not that there's not an inflammatory component causing this. I know of no treatment that you can offer the patient. Perhaps some of the other panelists may have this. Once you have that condition, people have tried steroids in the past. I've tried steroids also. I don't know if I get a response. Some people do get better, as you know, without any treatment. And but I don't think there's been any long-term studies. There have been a couple of trials that have looked at treating these early to reduce the apoptosis, but you'd have to treat them within probably 24, 48 hours, at the latest 72 hours. And the results of these trials has not been good, and the drugs have not gone forward. Anybody on the panel have any ideas?
I think you had a good point, David. Just rule out giant cell arteritis with like sedimentation rate, C-reactive protein, because that could be treated with steroids to protect the fellow eye. But you're right, it's very challenging to treat non-arteritic ischemic optic neuropathy.
I have a question to all the panelists, Mies. We have talked about the topical therapy. We have talked about surgical intervention. Do you feel the role of subtenons, triamcinolone, or steroids at, in some particular cases? In what situations?
Well, the problem I have with subtenons, and again, I'm not a uveitis specialist, is I'm not always sure, number one, where it's going, and number two, like, you can't turn it off. But we use subtenons in some trials. That's been given at the end of surgery. If you're doing subretinal delivery, so it is used. I think it does help in some cases. Does eliminate the need for other topical steroids.
Yeah, my experience is that, yeah, it is in some protocols, and so I think it adds to the additional immunosuppression post-operatively, and so I think it does help. I think, if the question is, can you rely just on that alone? I'm not sure, but it's often used as part of the overall regimen.
Okay. Hoya,
And
you
Paul,
have any
you
point?
mentioned a great complication that occurs with Luxturna, where you can have those pigmentary changes, the atrophy, without frank inflammation. Are you concerned about long-term safety of gene therapy then? Because a lot of this doesn't occur for years after you administer it.
Yeah, this is a vexing issue that we're dealing with right now. Everything we talked about so far, you can see cells, right? And, we suspect that there may be an immune response involved in this, type of perifoveal atrophy. Because in non-human primates, we see something similar where you see retinal changes, but really no cells. But then when you do histology, you see, infiltration of leukocytes. So we're only getting to understand this better now. And, unfortunately, a lot of the non-human primate safety studies that are done, before clinical trials, they only typically go out 2-3 months, right? Because, the answer is really, or the question is usually more acute, right, inflammation for safety. So I think longer term studies, will eventually have to be done, right, preclinically to try to figure this out, because in patients, we don't know if it's immune response or some sort of toxicity, from perhaps overtransduction.
Great points. I think it's been a great session. We're going to move on to our next session in Innovate Retina. Thank you to all of our speakers, Puya, Paul, and David Boyer, and of course, my co-moderator, Ashish Sharma. It was a great kickoff session. We'll turn it over to Juan.
Yes, thank you, Dana. Thank you, Ashish. Thank you, David, Puya, and Paul as well. We are now moving to our next session to see how we can learn of some of the new therapy that may be able to help some of this aspect. So with me, some of our colleagues here that you will be introduced very shortly, but our co-moderator with me today will be Professor Hamila Hazijarova, who is the chair of the Department of Ophthalmology at Charles University in Prague, the Czech Republic. And throughout the year, Jaga has been involved in a number of clinical trials, has been a leader in uveitis throughout the world, and especially in Europe. So we're very welcome to have her with us this morning. So Hamila, please proceed with our first speaker, please. Hamila.
Thank you very much for the nice introduction, Juan. And it's my pleasure to introduce David Almeida, who is the President and Chief Executive Officer of the Erie Retina Research, vitreoretinal surgeon at the Erie Retinal Surgery. And Dr. Almeida is involved in many clinical trials in retina and uveitis, and he will introduce us some new developments in the inhibition of IL-17. Please, Dr. Almeida.
Well, thank you very much for the kind introduction. It's great to be part of a wonderful group and a really exciting program overall. So I'm going to jump into it. We're really going to be talking about interleukin-17 inhibitors and what we can kind of learn from clinical trial updates that we have to date. There's that delay. So here's my disclosures, which are not directly relevant to this presentation. And so we're going to be briefly touching on kind of the overall understanding of IL-17 inhibitors, the current applications, what the clinical evidence shows, and then when we look at current trials, future trials, and then challenges, opportunities for treating patients with IL-17 inhibitors, we'll end on that topic there. So if we kind of just break them down very, very simply, and we know that IL-17 is a pro-inflammatory cytokine. This is involved in a lot of host defense systems, and so this is going to be a commonly targeted pathway. When we see here that as a pro-inflammatory cytokine, really any idea or any approach to neutralizing IL-17 is going to be to minimize inflammation. And at least currently, we see that the evidence suggests that there's good utility in inflammatory and autoimmune conditions using IL-17 inhibitors. And so if we, take a view from 30,000 feet and see exactly what's going on with the pathway, we can see there's going to be multiple access points to blocking this pathway, both at the cytokine level and at the receptor level. And so if we now break into the current ocular applications of interleukin-17 inhibitors, so the first therapeutic antibody that was approved was for psoriasis, now going on almost 10 years, or about 80-year marks, but we have additional FDA-approved IL-17 inhibitors, and the main indications are going to be psoriatic arthritis and plaque psoriasis. And so we're familiar with some of these agents. We've seen some of them, and we're going to try to stay focused on very much uveitis, vitreoretinal diseases. And so if we look on the right side here, we're looking at kind of both secukinumab, izakinumab, and brotherlab as a ways to inhibit, block these effects of IL-17 pro-inflammatory cascade. So when trying to get into the clinical evidence supporting IL-17, there's recent studies show that there's promise of this therapeutic modality, whether we think about it alone or in conjunction with other mechanisms of action in treating uveitis. So really probably the best studied one comes from our phase 3 MUST trial using secukinumab, looking at patients with non-infectious posterior uveitis. So this kind of showed us that, we could reduce disease activity, we can have good control, at least when we have compared to conventional immunosuppressive therapy and placebo. And most importantly, as we know with because we start blocking a lot of downstream effects that are involved in host immune functions and pro-inflammatory cascades, where we have good safety profile. With izakizumab, this is another monoclonal antibody that inhibits 17A. And so although this is more limited here, we're seeing that good favorable outcome as we get continued validation of this pathway for inflammatory disease. Sometimes I think it a little bit akin to early complement as you're trying to understand it, whereas complement applies to macular degeneration in IL-17 in the setting of uveitis. So we try to understand where the pathway exists and try to validate the pathogenic pathway, and then also the epiphenomenon that acts around that pathway that may have indirectly affect your actually outcomes with the patients that are being treated. Brotherlab is an IL-17 inhibitor antagonist that now actually blocks binding at the receptor level. So at least pharmacodynamically, we're going to be acting at a different site there. And with clinical trial data showing that this probably has a good robust response, but we are limited in the overall safety and long-term data for it. And so here we can see that at the receptor level, we're going to be able to influence the downstream effects in a different manner. In terms of razakizumab, this is an IL-23 inhibitor. This is, having done a PhD in pharmaceutical science and drug lead candidate optimization, this is an interesting one because by targeting the IL-23 inhibitor, you get a partial agonist effect going on. So depending on what other inflammatory mediators, in this case, really IL-23, you can indirectly modulate the IL-17 pathway. And we think that if we're going to have some of the downstream safety signals that are going to be burdensome or wanting to avoid related to blocking the T helper cells that produce IL-17, this may be a way that we can modulate, minimize, or at least improve the safety outcomes in these patients. And then, looking at the various target sites here that we all see it in different ways, depending on what kind of trials. And it's a great group that we've all been involved in various different trials involving these agents. So now, if we take it and really project into the future of IL-17 inhibition in uveitis, how does that look like? So we know that there's a bona fide mechanism of action there, and so there's probably potential to go over everything from non-infectious posterior uveitis, but we're seeing trials also being developed in scleritis and keratitis, and really the main thing is going to be revolving the safety profile, and then what's the dose regimen for these patients? Because these patients sometimes usually need more frequent treatment, and so they're not a set it and forget it type of treatment. And it really just brings us to the last section of challenges and opportunities as we move forward with IL-17, and at least in a broader application for our uveitis patients. So the potential side effects and the need for frequent injections, like I briefly mentioned, are going to be issues that have to be addressed on the treatment burden side of it. Not unfamiliar to branded expensive drug treatments. Cost of treatment will have to be ameliorated as well in terms of getting access to patients, especially in a consistent long-term aspect. And then when we think about the controlling the safety aspects and the downstream effects, that will, I think, will require second, third agents for best possible control when you think of IL-17 as your primary mechanism of action. In terms of ongoing opportunities, I know that a few of us are PIs on this Strondia Silverman trial. Izokibep is being currently treated for the treatment of intermediate posterior and panuveitis, non-infectious, and then really try to understand how these various inflammatory and autoimmune conditions can be modulated by using that IL-17 pathway. Reference here. So I want to say thank you very much. It's a niche topic, but I think an important topic that we'll keep seeing come up again as we try to address it, multiple mechanisms of actions in our uveitis patients. So thank you again.
Thank you, David, very much for that wonderful introduction to IL-17, and we will discuss a little bit more about that during our panel discussion. It is now my great pleasure to introduce one of our colleagues here, Dr. Dheeraj Grewal, who is an associate professor of ophthalmology at the Duke Eye Center. And Dheeraj has been involved in a number of clinical trials as both a retina and a uveitis specialist. And today he will focus his talk on JAK inhibitor. Dheeraj, welcome.
Thank you so much, Kwan, and thank you to the entire Innovate Retina team for allowing me to be a part of this excellent program. So I'm going to spend the next 8 minutes talking about JAK inhibitors. These are my financial disclosures. I'm sure everyone in the audience is aware of the need for having better therapeutics for non-infectious uveitis, which should be ideally an oral steroid-sparing agent with reduced frequency of administration, good control of macular edema, as well as early, effective, and complete control to prevent the sequelae that lead to irreversible vision loss. Now, David set me up nicely by introducing us to some of the basic immunology. And if you recall, the differentiation of the naive T cells into T helper 1 and T helper 17 cells plays a critical role in the pathogenesis of non-infectious uveitis. And furthermore, we know that Janus kinase, or JAK, particularly JAK1, and tyrosine kinase, particularly TYK2, are implicated in the differentiation of T helper 1 and T helper 17 cells through multiple cytokines, and these cytokines are some that we are very familiar with. These include IL-6, TNF-alpha, and even IL-17 that David just talked about. So it behooves us to look at inhibition of the the Janus kinases to control several of the downstream effects that these cytokines cause on the immune system. There is good data of the validity of pursuing the JAK pathway. We know that TNF-alpha expression, that is by the T helper 1 cells, is mediated by interleukin-12, as well as interferons type 1 and 2. And the anti-TNF pathway, we all know, is well validated with infliximab as well as the adalimumab, which has had phase 3 registration trials. T helper 17 cells are elevated in non-infectious uveitis, and they are both upregulated during active disease and then downregulated in response to treatment. Now, JAK inhibitors prevent the JAK-STAT signaling pathway, and they also reduce IL-17 production by the T helper 17 cells. So a little bit upstream from what David just talked about. JAK1 and TYK2 inhibition has the potential to reduce the differentiation and thereby target more than one single cytokine and have potentially a broader effect. For example, the naive CD4 T helper cells can be, their conversion into T helper 17 cells can be regulated by IL-6 and IL-23. And you might be familiar with agents like sarilumab, which is studied in the phase 2 Saturn study, or tocilizumab, which is studied in the STOP uveitis study, which are IL-6 agents, and ustekinumab, which is an IL-23 inhibitor. There's another IL-17 agent, secukinumab, which David just talked about, which is a downstream regulator. So this brings us to the fact that do we have any experimental data to suggest that JAK inhibition is a valid pathway? And yes, we do have data from experimental autoimmune uveitis models showing both tofacitinib, which is a JAK1 and 3 inhibitor, as well as filgotinib, which is a selective JAK1 inhibitor, showing reduction in inflammation. Furthermore, there's also some evidence that there is differentiation between JAK inhibition and purely IL-17. For example, JAK inhibition has been shown to reduce cellular infiltration in the eye in this experimental autoimmune uveitis model, which is something that IL-17 inhibition did not. So where do we stand with the current clinical data with JAK inhibition? In uveitis, so far, our data is limited to smaller case studies, which have shown relatively promising effects, but recognizing that these are smaller studies that have looked at non-infectious uveitis, predominantly in the context of association with juvenile idiopathic arthritis. And overall, there has been a favorable response with reduction in macular edema, as well as anterior chamber cell inflammation. There have been some pilot studies, both prospective as well as some retrospective data out of Washington University and the Cole Eye Institute, which have looked at the effect of JAK inhibitors in non-infectious uveitis. But really, our most robust data to date comes from the filgotinib phase 2 study, or the Humboldt study. This was a phase 2 clinical trial which had planned for 110 participants, was then expanded to 248, looking at adults who had active intermediate, posterior, or pan uveitis with active disease despite 2 weeks of oral prednisone. The primary endpoint was the proportion of treatment failures by week 24, and these were based on predefined treatment failure criteria, which I'm sure all of us are familiar, those who have taken part in uveitis clinical trials, as chorioretinal lesions, anterior chamber cell inflammation, which is Hayes grade, as well as ETDRS visual acuity. And the two arms in this placebo control trial were either filgotinib 200 milligrams daily or a placebo. It was a 52-week study, and all participants underwent a 15-week prednisone taper. Now, the study was unfortunately halted prematurely due to business reasons. But out of the data that we have so far, the filgotinib arm had a treatment failure rate of 37.5% at week 24, which was significantly lower than the placebo arm, which had close to a 70% treatment failure rate. Correspondingly, there was also better visual acuity and reduced retinal thickness in the filgotinib arm. And these are all suggesting to the potential efficacy of JAK inhibition. If you look at the clinical trial design again, you'll note that there was a 15-week steroid taper, and then the two arms, which was a placebo-controlled study. Now, when we look at the Kaplan-Meier plot, and this is really taking playbook out of the visual trial data or visual trial design, you'll note that the two arms of filgotinib and placebo really start to separate around week 16. And then the divergence in terms of the probability of treatment failure continues out to week 52. Looking at the reasons for treatment failure after week 6, which was the first time point when treatment failure was defined, it was pretty evenly split in the filgotinib arm in terms of new chorioretinal lesions, anterior chamber cell worsening by 2 steps or more, vitreous Hayes grade worsening by 2 steps or more, or reduction in 3 lines or more of visual acuity. So overall, a very promising molecule, but was unfortunately halted prematurely. So where do we stand now, and what are the currently active clinical trials looking at JAK inhibitors? So Priovant Therapeutics is conducting a phase 2 study, the Neptune study, that is looking at a small molecule TYK2 JAK1 inhibitor, brepocitinib, which is administered orally. This is again a study that is looking at non-infectious intermediate, posterior, or pan uveitis with similar criteria that we just reviewed. And again, it has a pretty broad effect on several cytokines downstream. This is a study that is looking at 24 participants, and of note does not have a placebo arm, but has a 2:1 randomization in the brepocitinib 45 milligram dose or a 15 milligram dose. In addition, the duration of the prednisone burst provided at the initiation of the trial is over 6 weeks, as opposed to 15 weeks that was in the filgotinib arm. The study is going to be conducted up to 52 weeks, and as of this month, the trial is now fully enrolled. Alumis Therapeutics is also conducting a phase 2A randomized double-masked study looking at ESK-001, which is an TYK2 inhibitor, so selective TYK2, and is an oral small molecule. And it blocks the downstream phosphorylation of interferon alpha, IL-12, and IL-23. This is similarly designed, looking at patients who have active intermediate posterior or pan uveitis, non-infectious, with similar entry criteria. And again, there are two arms. There is no placebo arm. The two doses of the molecule are 40 milligrams twice daily or 10 milligrams daily. And patients will be randomized 2:1 in these doses. There will be a 12-week prednisone taper at the initiation of the clinical trial. And the goal of the trial is to enroll 30 patients, and the trial is now actively enrolling. So overall, we are eagerly awaiting the results from these two clinical trials because there are several possible advantages and differentiating factors for JAK inhibitors over TNF inhibitors or biologics, which are currently one of our frontline therapies. It's an oral route of administration, which is clearly an advantage. There are possibilities for differentiation in terms of response, in terms of macular edema and control across different phenotypes, which could be another factor to look at the efficacy. There are some questions, however, that remain to be answered. For example, from our rheumatology colleagues, we have learned that JAK inhibitors may be limited to use in those patients who have failed TNF alpha, and whether such a restriction, either from a clinical trial standpoint or from a payer standpoint, will be applied to uveitis remains to be seen. There is also some concern about cardiovascular risks associated with JAK inhibitors, but that is predominantly based on a post-marketing surveillance study or the oral study, which did look at patients who were either on a JAK inhibitor or those who were on TNF alpha, and found that there was a higher risk of cardiovascular events in those on JAK inhibitors. But we do need to recognize that that population was significantly older in the JAK inhibitor group versus the TNF alpha group. But overall, it's an exciting time, and we do look forward to the data. Thank you.
Thank you very much, Dilraj, for this great overview. And we leave again the discussion to the end of the section. And now it's my great pleasure to introduce the next speaker, who is Guangdong Nguyen, the professor of ophthalmology at Stanford University, clinician and researcher at the Bayer's Eye Institute, and according to my knowledge, one of the most experienced researchers in the field of innovative treatments for uveitis. And he will share with us the new developments for treatment of non-infectious uveitis. Please, Guan.
Thank you, Jagat. It's my great pleasure to share with you some of the additional study that we're looking at. Our disclosure is listed here. You just heard David and Dilraj discuss some of the ongoing clinical trials that are addressing, for example, the interleukin-17 and the Janus kinase inhibitor. There's also pathway involving corticotropin that involve as well as mTOR inhibitor. Today, however, I'd like to focus on two different aspects. First is interleukin-6 inhibitions, some of the work that we and others have done and some of the ongoing trial, as well as another entity. This is attacking antigen-presenting cell locally with laquinimab. So let's just begin first now with the topic of IL-6 inhibition for patients with non-infectious uveitis. We begin the story with tocilizumab, which is a recombinant anti-human monoclonal antibody that had been shown to be directed against the interleukin-6 receptor. Indications thus far has been that this particular molecule has been approved for rheumatoid arthritis and juvenile idiopathic arthritis. We started about 6 years ago the study called the Stop Uveitis that been mentioned with Dar. With that, we were looking at two different doses of tocilizumab, 4 milligrams versus 8 milligrams at the treatment of patients with non-infectious uveitis, and the results were quite impressive, showing that the tocilizumab was able to improve macular edema as well as improving in visual acuity and show significant benefit for the patient with this in this open label study with that aspect. And the reduction in macular edema was done without any other treatment. So just by IL-6 inhibition alone, one can see significant benefit. Subsequently, we also look at what other endpoint that we can consider, because in addition to vitreous haze, we know that in uveitis of inflammatory disease, that other endpoint important. So we begin to look at a composite endpoint outcome to assess that. And with that, we have learned quite a bit of aspect from there. We learned in terms of various other factors that may be considered together in assessing our patient with uveitis. And together, we feel that a composite scoring system would serve as a better way to assess response to therapy in future clinical trial. And this, certainly we have communicated with colleagues, we certainly communicate with Dr. Wiley Chamber and other group at the FDA as well. So hopefully moving forward, we will be able to learn that much. In addition to tocilizumab, there's another molecule which is an interleukin-6 inhibitor, and that is serelumab. And this is a fully humanized interleukin-6 receptor monoclonal antibody to recognize both the membrane-bound as well as soluble form. So we begin this study with the Saturn study that was conducted about 4 or 5 years ago as well. And so in this Saturn study, we were able to look at the role of serelumab with that. And again, we see very impressive outcome with that. This is the mean change in best corrected visual acuity, clearly showing an improvement of serelumab versus placebo. In addition, when we look at subject with a significant amount of edema initially, then the change in visual acuity was quite significant, even more 18 versus 4 letter. And again, showing the ability of IL-6 inhibitor alone in reducing macular edema and controlling inflammation. Something similar with the change in OCT we can see here. This is overall across all the subject. And then in subject with significant macular edema initially, that also shows significant improvement as well. So with that, we showed the result of this study of that, and again, led by Hawker and her team in the Czech Republic and across the various colleagues around the world. We published that, and since then. So since then, what have we done? What have we and others have done? So certainly from our own practice here at the Bioinstitute at Stanford, we have continued to look at what IL-6 inhibitor in the form of tocilizumab have done. And here is the comparison study outcome of the infliximab with the tocilizumab therapy in non-infectious retinal vasculitis. We subsequently also look at what happened in patients who have failed traditional IMT or anti-TNF inhibitor, and then we switch them over to tocilizumab, whether that make a difference. And that one just came out a few weeks ago with that as well to show that it definitely show benefit. So with that, we asked the question, we at uveitis and retina specialists have been using this as a form of intravenous or subcutaneous systemic delivery. What happened if we could get this a role for local therapy or not? So this is one of the molecules that currently in clinical trial right now. This is RG6179. This is an anti-IL-6 monoclonal antibody for intravitreal delivery. It is recombinant fully humanized IgG2 monoclonal antibody engineered for intravitreal delivery in patients with ocular disease. The FC region was designed to reduce systemic exposure. So certainly one can ask the question, systemic exposure, that means it's only for the eye only. And what happens if we have systemic disease that also require treatment? However, the intravitreal administration with fast systemic clearance hopefully will minimize any potential for systemic side effects. And then the half-life so far for RG6179 is approximately about 7 days or so. And it inhibit both the IL-6 cis and trans signaling pathway. And currently, this particular molecule delivered intravitreally, RG6179, is currently in clinical trial for uveitic macular edema and diabetic macular edema. So this is a continuation of our work and other that take interleukin-6 inhibitor further, and in this case, offer an alternative in form of intravitreal delivery. In addition, there's another molecule called KSI-501. This is a novel bispecific antibody biopolymer that conjugate targeting both IL-6 as well as VEGF. So in other words, in the same compound, we have attacked both the VEGF as well as IL-6. KSI-501 inhibit angiogenesis and normalize the inner and outer blood retinal barrier. The dual inhibition of VEGF and IL-6 confers superior, hopefully, normalization compared to either anti-VEGF or anti-interleukin-6 monotherapy alone with that. Currently, KSI-501 is in clinical trial for diabetic macular edema, with the goal that perhaps it can also be moved on as well into ocular inflammatory disease as well. So thus far, I've shared with you some of the additional work that has been done to look at further the role of interleukin-6 inhibition in ocular inflammatory diseases. Now let's look at another molecule. This is laquinimod. This is an antigen-presenting cell and immune tolerance activity for this aspect here. So laquinimod target the antigen-presenting cell and induce immune tolerance. Here you can see that the laquinimod like the antigen-presenting cell to an and pro-inflammatory. So it's blocked that pathway so that it will decrease activation of pro-inflammatory cell while at the same time activate the regular T cell and induce immune tolerance with this aspect. Laquinimod has been moving forward to look at potential novel therapy for different eye disorder. The initial focus for this has been non-infectious uveitis, certainly given its pathway, but it's also been looked at because of the aspect that it can reduce the pro-inflammatory and angel response, perhaps looking at other diseases that may contribute to that aspect, especially those that can produce macular edema. So whether or not laquinimod will have the role in that as well. Laquinimod has the advantage that it can work both topically and orally. So for topical laquinimod, it has been done in preclinical study, shown comparable activity compared to other anti-inflammatory drugs. In addition, it can also be administered oral as well, and that can offer an advantage regarding where we want to target, what kind of disease, whether it's ocular disease only, or whether it's only systemic disease as well in this aspect. So for this aspect, again, the inhibition of experimental uveitis in preclinical study by laquinimod is associated with reduction of pro-inflammatory T cell and cytokines, as well as increased anti-inflammatory regular T cell as well from that. The phase 1 study of laquinimod eye drop in healthy subjects so far has been quite well. Positive safety and tolerability have been shown, and this data will be presented at the upcoming International Ocular Inflammation Society meeting, IOS meeting in Berlin, that coming up in September with that, and additional data from laquinimod will be presented there. Thus far, the program in eye disorder of laquinimod seems to be promising. A lot of safety has been done already, and now we're moving forward to begin to test it in various indications to also look at whether or not topical delivery will have sufficient penetration into the vitreous and in the retina as well for this aspect. So in summary, follow up with David Almeida on IL-17 and Direct Grewal on JAK inhibitor and TYK inhibition. We certainly recognize that there's a critical need for well-controlled randomized prospective study for uveitis therapy. We need a safe and effective agent for that. Certainly, we want to go to a targeted therapy with biologics, such as interleukin-6 inhibitor or JAK1 inhibitor. We certainly look at the different mode of therapy with laquinimod, where you can affect the antigen-presenting cell as well. And in addition, we didn't go over, but there's other therapy in development right now for intraocular vectorized molecule and for other aspects as well. And together with that, we always keep in mind our concept that is the goal for any therapeutic approach, whether we treating ocular inflammation in uveitis, is no tolerance to any degree of inflammation. We in ocular inflammation uveitis has stressed and emphasized this principle throughout the decades. Some of our colleagues in retina may not have necessarily believed addressing us until now that we begin to see inflammation in various retinal therapy treatment that have led to significant deterioration and put a hint in that. So now I think pretty much every one of us in the area of ophthalmology have recognized the goal of no tolerance of any degree of inflammation with that. With that, I'll end my presentation and let's move forward. Thank you.
Thank you very much, Kwan. These are exciting prospects for our patients. So I'm very happy to introduce the last speaker in this session, and that's James P. Dunn, who is a director of the uveitis unit at the Wills Eye Hospital and professor of ophthalmology at Thomas Jefferson University. Professor Dunn is a leader in uveitis and has helped many uveitis specialists to be trained. And I'm happy to introduce his talk, which is how to employ combination therapy in non-infectious uveitis. It is yours.
Thank you. So I have no personal disclosures for this. I'd like to second the other speakers that have commented how grateful I am to be invited to take part in this. So the learning objectives for this talk are to describe some of the evidence-based approaches to treatment selection and management of non-infectious uveitis, to discuss pediatric patients with JIA-associated uveitis, and to discuss some of the strategies for interprofessional management of patients with chronic non-infectious uveitis. So non-infectious uveitis encompasses a wide range of ocular inflammatory conditions, and it's important to keep in mind that these may not all be the same. In the same way that there are many different types of arthritis and many types of cancer, it certainly makes sense that there are many different types of uveitis, and the pathophysiologic mechanisms for Behçet's disease may be very different from those for, say, serpiginous choroidopathy. Anti-uveitis is the most prevalent form and comprises about 90% of patients in private practice, but more like 50% in academic centers, and intermediate, posterior, and panuveitis comprise the other half in academic centers. There are a variety of risk factors for non-infectious uveitis, including smoking and vitamin D deficiency, the presence of other autoimmune diseases, presence of other medical conditions such as preeclampsia or eclampsia. Stress may play a role, although it's difficult to quantitate stress. A number of medications, particularly the checkpoint inhibitors. Interestingly, pregnancy seems to be protective against many types of uveitis. Pediatric non-infectious uveitis comprises a relatively small percentage of overall uveitis cases, less than 15%, but severe ocular complications are common. Huge impacts on the quality of life are present. A significant percentage of these cases are associated with systemic diseases, particularly juvenile idiopathic arthritis. And a number of different biomarkers have been developed, although the clinical significance of these remains uncertain in many cases. So the first case is going to be a girl with JIA-associated uveitis who had 2+ cell in the right eye, chorotic precipitates, and had a history of polyarticular juvenile rheumatoid arthritis, was ANA positive and rheumatoid factor negative. Initially, there was just anterior segment involvement. She was treated with topical corticosteroids. Children, remember, have a higher incidence of steroid-induced cataract and glaucoma, so we try to minimize the risk of that, although studies from Jen Thorne have suggested that low doses of topical steroids may be relatively well tolerated in kids. When she developed some joint effusion, she was treated with oral NSAIDs, and then the possibility of methotrexate to treat both the systemic and ocular disease was raised. In children, there's very much a multidisciplinary approach. You need to take into account the role of the ophthalmologist, the pediatric rheumatologist, the pediatric ophthalmologist, and the pediatrician themselves. Side effects of steroids, of course, are similar to those in adults, but we have the additional increased risk of, in patients treated with oral steroids, of growth suppression. So there's a significant interest in steroid-sparing immunosuppressive therapy, including the biologic agents. There's sort of a sequence of steps to treat these patients. We often start with corticosteroids and then start with conventional disease-modifying anti-rheumatic drugs and then go to biologics. The Sycamore study showed that the combination of adalimumab and methotrexate could be very helpful in patients refractory to conventional therapy. And tocilizumab may also play a role, although that's unclear. So when she started methotrexate and increased to 25 milligrams subcutaneously once a week, she generally did well. She needed some topical steroids as a little booster agent. But because of side effects on the methotrexate, the question was, should something else be added? And she was seen with her pediatric rheumatologist. As Quan had mentioned, our treatment goal is to reduce and really to eliminate inflammation to prevent vision loss, recurrences, and complications. We generally don't do a lot of regional corticosteroid injections in children because of the concerns about cataract and glaucoma, but they can be used in some cases. They do have a rapid effect. They can minimize some of the systemic risks, but you have to keep in mind the particularly severe local side effects of regional steroid injections. So because of her progressive unhappiness with methotrexate, she started adalimumab while on a tapering regimen of methotrexate. The goal in many cases of low-dose methotrexate therapy in patients treated with things like adalimumab is to reduce the possibility of antibody formation to the anti-TNF drugs, which can reduce the drug efficacy. I'm not going to talk a lot about oral corticosteroids. They certainly have a role in the treatment of non-infectious uveitis. They can be very effective as initial therapy, but unless you can get the doses down consistently to 7.5 milligrams or less, ideally 5 milligrams a day or less, they are not generally considered useful as monotherapy because of the numerous side effects. So when we need to consider immunosuppressive therapy, there's a number of different approaches we can take. Conventional immunosuppressants, including antimetabolites, T-cell inhibitors, less commonly alkylating agents. And side effects of these can include, depending on the drug, GI symptoms, hepatotoxicity, nephrotoxicity, hypertension, and of course, the risks of myelosuppression and infections. Biologics are generally better tolerated, but still have their own particular side effects. So when should you consider a biologic? Well, in patients that, based on the MUST trial, although the 7-year data favored the role of immunosuppressive therapy, there's clearly a role for local corticosteroid therapy as well. I think probably the key point that I've tried to take out from the MUST trial at 7 years is that combination approach is really important. Many of these patients needed supplemental steroid injections or steroid implants for flare-ups while on immunosuppressive therapy. So it's not an either-or approach. It's both approaches can be helpful, and both approaches in combination can be particularly helpful. The adverse outcomes in the MUST trial were pretty much as expected, a much higher incidence of glaucoma and cataract, although perhaps some of the newer steroid implants may have lower risks of these. One of the other interesting findings in the study was that patients on immunosuppressive therapy did not have an increased risk of infections in the study, which is important for patients and their families to understand. The POINT study showed that intravitreal therapy, either as the dexamethasone implant or intravitreal preservative-free triamcinolone, were more effective than periocular steroids. And that the results of the POINT study had a big impact on at least my clinical practice. The MERIT study just released its data. This was a 1-to-1-to-1 randomized trial of intravitreal methotrexate to ranibizumab to the dexamethasone implant for macular edema in patients with controlled uveitis. And the data here, which have not yet been published but will be soon, showed that intravitreal dexamethasone was much more effective in terms of improving vision in these patients. All 3 arms showed improvements in retinal thickening, but only the steroid arm, which showed the greatest decrease in thickening, showed visual improvement. So that was sort of disappointing because methotrexate was felt to be a real potential option as non-cataractogenic and non-glaucomogenic. It just didn't pan out in the study. And then finally, the ADVISE study is almost completed enrollment. ADVISE is looking at patients with non-infectious uveitis who are randomized to conventional immunosuppression versus adalimumab. When that study gets enrolled and completes, I think we'll have some more data. There are some preliminary data that suggests that adalimumab may be more effective as monotherapy than any of the conventional immunosuppressants. So we'll see how that goes. But I think still the key point to understand is that combination therapy is probably going to be the way to go for many patients. And I'm not going to have time to go into all of that, but combining things like adalimumab with an antimetabolite, or even combining conventional immunosuppressants like an antimetabolite with a calcineurin inhibitor may be as effective and certainly less costly than many of the biologic approaches that have been talked about so far today. So I'm running over time, so I'm going to finish up with that and we'll go on to the next speaker. Thanks very much for having me.
Wonderful. Thank you, JP. And with that, we're now going to move into our discussion group here with various colleagues. And in addition to our speaker, we'd like to introduce also Dr. Mark Dacey from the Retina Consultant of Colorado. We will hear from Mark later on as well as Dr. Briani, whom we heard from first session. And with that, let us start with our discussion. Jaga, do you have any question for our panelists so far?
Yes, thank you very much for that. I would be very interested actually if you could answer my question. The laquinimod, this is quite exciting. The topical use in the study, is it going far enough into the retina if it's just topical application?
So, you asked excellent questions, and certainly for many of us who have done clinical trial over the last 2 decades, there's been very few clinical application of a topical drug that can lead to sufficient penetration into the eye and the retina. So for this study, we actually are proceeding with the study at the Bio Institute, looking at whether or not topical laquinimod will even get into the vitreous and the retina, and that is being performed as we speak, planning right now. So hopefully in the future, we'll be able to get that there, because from the preclinical model, it say that it can. However, we want to make sure that we can demonstrate it in human subject for that.
Thank you.
So let's have the question next for our group here. David, with IL-17 inhibition, thus far that you have seen, some of the potential adverse event that patient may have experienced has been, for this particular one, has been fungal infection with that been reported previously. Do you have some thought into why it's just that? Because usually we don't see, for example, fungal infection unless the patient is really immunocompromised. And from the pathway, it doesn't seem to be like that. Can you perhaps suggest a mechanism or thoughts for this one, please?
Yeah, no, thanks for the question. I think we see it, there's a couple of ways to break that down, Kwanda, to make it useful. One, at least when we see with IL-17 inhibition, the associated risks of candidiasis are going to be oropharyngeal, like upper respiratory, esophageal, and cutaneous for the most part. And we know that that's because that the T helper cells, the IL-17 pathway is going to be really active against those types of infections. Luckily, when we move over to the retina and uveitis side of it, we don't see it as much. And really the best assessment really comes from the Lancet study from maybe it was a couple of years ago that really looked at this as a global population of patients that are being treated with IL-17. So I think the short answer is that it's going to be that pathway is involved in candidiasis. So knocking it out is going to lead to these kind of ENT types, although that's much less a signal in vitreoretinal and uveitic diseases.
Thank you, David.
I would have another question, actually, and maybe for all the panelists. Do you think if we now employ anti-IL-17 treatment or JAK inhibitor treatment, do you think a combination of these would be safe enough for the patients?
Mark, you like to attack that question, Mark? What do you think? Combination of some of this biologic, for example.
I don't think this has been studied. There's some really preliminary animal models for this, but I think the main concern would be oversuppression of the immune system. That if you're attacking at multiple critical junctures, that you might lead to higher rates of recurrent infections and poor tolerance. So a lot of times with biologics, we'll pair traditional immunosuppressants and methotrexate, mycophenolate with those, often in an effort to prevent drug-induced lupus and perhaps for some synergistic benefits between the two. But I've not been brave enough to try multiple biologics in the same patient at the same time.
I think we have to be really careful about approaching along those lines. One of my favorite movies is Jurassic Park, and there's that quote from Jeff Goldblum, and they talk about it's impossible for dinosaurs to reproduce, and he says nature will find a way. And it does. And we see that in all sorts of diseases. We see in asthma, for example, if you block one pathway, the leukotriene pathway kicks in and the patient still has disease. And I think there's a tendency to think about biologics as that old game Newton's Cradle, when you pull one ball out and you release it and you get this very specific and predictable response at the other end. And I don't think biologics work that way. I think there's a lot more black box stuff in there. And I think the concerns about infections, IL-17, IL-23 are known to be important in preventing fungal and bacterial infections. And I just think we need to proceed very, very carefully when we start combining those.
Thank you, JP. Thank you, Mark. Any other comments, thoughts?
I'll add one to James or to Dilraj, who present on topic, or Kwan. Do you think that combination will become less of a concern, more of a concern, or unknown as you get to really high affinity drug types? So our side, we're lucky enough to have the first patient dose for the Optic One Alumis ESK study there, and that's a really high selective tyrosine 2 along that pathway there. Do you think those really high affinity ones are going to make it safer for combination therapy, or there's still so much crosstalk that exists and so much dangers of off-site or off-target inhibition to preclude that?
Diraj, what do you think?
Yeah, I agree. I think we just don't have the data. And I would argue that the way Dr. Dunn suggested, a combination of local therapy in addition to systemic therapy may be a safer approach, because we could titrate our dosing of local therapy to make up.
That's expected. I think we may have lost Diraj for Lucas. Boya, what do you think?
Just continuing where he left off, I mean, I think that is a great path, combining local and systemic therapy, starting therapy for maintenance therapy, local therapy, initially to calm things or for breakthrough inflammation. It's going to be hard, just uveitis trials in general are just so hard. It's so hard to show benefit in the studies that we've done over the years. We've only shown Humira, been able to get it FDA approved. So it's hard to show efficacy just by the parameters that we use and the complexity of the diseases. And when we start looking at combination therapy with multiple immune suppressants, other than personal experience or small case series, we're not going to really have data that we can rely on. So it's going to be anecdotal and small series. So I'm sure, we all have patients that are on a combination of therapies. I do now, as we all do. But I do think I agree, incorporating local therapy.
On the topic of combining local and systemic therapy, there's also the scenario where quite often you'll have the uveitis well controlled with a systemic agent, but there's still the issue of persistent uveitic macular edema. And so often it's a necessity to use both, where you need dexamethasone implant or Xipere for the uveitic macular edema, even though the disease itself may be adequately controlled on adalimumab or mycophenolate. So I think combination therapy, to be able to address the persistent macular edema that will exist often years down the line after the uveitis is adequately controlled, is an important subtype here.
Yes, the important topic of uveitic macular edema will be discussed actually in session 3, so please stay tuned for that there. Jaka, do you have additional question for our panelists?
I think there is one in the question and answers chat, and it's probably for Dilraj, if he's present. Given that filgotinib is licensed in Europe for rheumatoid arthritis, do the panel think there is a way forward to for non-infectious uveitis, if it is worth of phase 3 study?
I do not know if Dilraj, you backed. If not, I'll attempt to answer this question. So that is an important question, and certainly, oh yeah, Dilraj, you heard the question? The question, Dilraj, is that filgotinib has been approved in Europe, and especially UK, for rheumatoid arthritis. The question is, can we conduct a phase 3 study of filgotinib for uveitis in the United States here? And so you mentioned some of the aspects of filgotinib, so you can explain again why we could not proceed with that.
Sure, I apologize for the interruption. Yes, I think it is certainly feasible to conduct it as long as the manufacturer has an interest and the ability to support the trial. Because remember, this trial was not halted for safety or efficacy reasons, but rather was a business decision. And I think it becomes a discussion even from a commercial standpoint about the level of motivation to pursue it. There were some concerns perhaps about effects on the sperm count in rat models. That was a potential concern, but has never been studied or evaluated in humans. But I think that's where we are at the moment for filgotinib in uveitis.
So to also complement what you say, the question started with the fact that filgotinib has been approved in the UK for rheumatoid arthritis. However, in the United States, when the manufacturer tried to apply for filgotinib to 2 randomized controlled trials for rheumatoid arthritis, for filgotinib for rheumatoid arthritis, it was not approved in the US for rheumatoid arthritis. And hence the manufacturer decided without a rheumatology, and where they did not want to just pursue with uveitis alone. And so unfortunately, that's why we don't have it. But that can tell you the difference in terms of how each of the regulatory agency look at the data, because in the US, it did not get the approval for rheumatoid arthritis. Perhaps we can ask one last question for this before we move, and that's an important question like this nature. So far in this session, we have indicated to you that there's several clinical trials moving on, and as we say, to target specific, whether IL-17, whether it's JAK, whether specific aspect there. So with this type of treatment, what do you think we should do toward our effort with precision medicine? In other words, in different specialty in medicine, people have tried to be as much try to treat each individual patient as precise as possible. Do you think that we can move to turn, for example, let's say when Mrs. Smith first presented any of our clinic, we can perform testing, whatever we want to do, to identify what is it in Mrs. Smith that is maybe abnormal into the interleukin or cytokine or whatnot, that we can then try to address that. You think, how far do you think we're away from it? JP, what do you think? You think we can see in the next decade that we can see something like that happen?
I don't know if it's going to be in a decade, but I think that's, we'd like to go to. I think it's important to understand that we lack a lot of the good cytokine analysis in patients who have different kinds of uveitis. And there's no, as I said before, there's no reason to think that, they have the same pathogenesis. We know that TNF blockers work great in Behçet's disease, but maybe not so well in other disease. We know from the research component that, for example, IL-17 may be more involved in axial spondyloarthropathies, and IL-23 may be more involved in inflammatory bowel disease. So there's just so much we don't know about these things in the eye. I'd love to see more cytokine analyses from anterior chamber taps and vitreous taps, if that were possible, because I think we're making a lot of assumptions that may not be justified.
Holger, what are your thoughts on this point from European perspective?
Yeah, I think this is exactly how it is. And I think this is still to get the analysis to the clinical point. I think in the research, it's no problem at all now with the new sequencing methods and the broad spectrum analysis for 500 proteins at once from tiny 50 microliters of aqueous humor. But the thing is, to get this into clinical practice will be probably taking the time, because we need to develop the specific panels for the analysis and to get it into clinical practice for us to use.
Any last comment from our colleagues? That's certainly a goal that we should aim for.
I think it's a fantastic goal to shoot for. I would love to see more data on like long-term remission with the various agents in the meantime, to say, yeah, if a patient comes in and I start them on adalimumab tomorrow, if I treat you with this for 3 years, do you have a 70% chance that this goes into a durable remission, or 85 or 60? I don't know what that number is. But from our oncology colleagues, it's really nice to be able to share that information out front with patients. I think that's a great kind of intermediate goal that we might have as a field, to be able to get some of these remission rates on the way to these cytokine analyses.
Great. With that, Amir and I would like to conclude this session 2 on pharmacotherapy here. And we thank Dr. Dunt, Dr. Daisy, Dr. Amida, Dr. Diana, and our colleague here for joining us. And we are now turning over to session 3 to be led by Professor Muthanjaya and Professor Neri. Thank you.
Thank you.
Thank you, Kwan. Thank you, Jamila, for an excellent session. We're moving on to section 3, which is managing inflammatory macular edema, which is the bane of existence for retina specialists and uveitis specialists alike. I am so pleased to be joined not only by our speakers, who will introduce, but by Dr. Pier Giorgio Neri, who is a clinical professor and medical director at the Cleveland Clinic, Abu Dhabi, and a uveitis specialist. So Pier Giorgio, can you lead us off?
Much for the introduction. It's now my great pleasure to introduce our first speaker, Professor Mark Desmet, and he's the founder and director of the MIOS Retina and Uveitis Center in Lausanne, Switzerland, and he's going to talk about advantages and disadvantages of systemic therapy. Mark, thank you.
Thank you very much. It's a pleasure to be here and to be able to participate in this wonderful meeting. I'm just trying to get my slides up and going. I've just clicked on Control Studio Slides. Let's see if something happens. Yes, there we go. So I'll be talking to you first about systemic therapy for uveitic macular edema, and about pros and cons. And in many ways, you've already heard a fair amount about that. We'll start by this first slide about the MUST trial that you've already seen. And in this study, obviously, there was a large group that were treated systemically. And what we see is that at the end of 2 years, there's really not much difference between whether they were treated systemically or with an intraocular implant with regards to the resolution of macular edema, and also with regards to activity. In fact, if we look at the results, we see that there is at 2 years, 65% of patients that were on systemic therapy that improved, 52% at full resolution. The biggest difference was really that those patients treated systemically had probably more visits to their GP in order to look at things such as upper respiratory infections. And they were using the recommendations from a panel that was published in 2000, where you try to reduce the steroids quickly. In those days, we talked about 10 milligrams, under 10 milligrams. Now it's under 7.5. You've heard about that before also. Before we go to other medications, let's talk just for a little while about prednisolone systemically given IV, methylprednisolone. This is a recent study that looked at pulse steroids. The advantage of pulse steroids, in fact, is that you can get a very quick effect within, in fact, a few days, as you can see here, both in terms of BCVA as well as the reduction of the macular thickness. And you're able to reduce the use of medications. It doesn't mean that you'll stop using systemic medications, but you can readjust what you're giving. And in terms of success, 38 or 50% at 1 month were edema-free. And with regards to, so this is a shock treatment that can tell you that you are dealing with inflammation and should go on with what you're doing. And with regards to adverse effects, yes, there are some. It should be done under good control since you're giving high doses IV. The major ones may be the induction of diabetes, increase in blood pressure, fluid retention. Now, of course, we prefer using other medications, and systemically, the two most commonly used are methotrexate and mycophenolate. And in the FAST study, patients were randomized to one or the other, maintained on treatment for about 6 months, and then potentially a switch was made. In fact, whether you switched or not, the results were about the same in both groups. There was really no major difference. And in terms of improvement, it was defined as 20% reduction. It was relatively significant in both populations. Maybe mycophenolate as such is a little bit better if you're looking at the side effect profile. They're quite similar. You end up getting some GI upset, potentially some diarrhea. But in fact, the ease of use with regards to mycophenolate these days seems to give it a slight edge. Now, you've heard about anti-TNF in some of the previous talks, and yes, it is very effective, both in trying to control the uveitis as well as get rid of edema. If anything, here, the results are better than what you've seen in the MUSTA trial. So the dose was sub-Q every 2 weeks for about 6 months with good results. And if you try to compare adalimumab versus infliximab, there is in fact very little difference with regards to clinical remission or the risk of having a relapse. It might be a little bit better in terms of relapse if you're using adalimumab, but both are in fact quite effective. Similarly, if we now look at anti-IL-6, which also works quite well in being able to reduce macular edema, 14 of 25 resolved within a fairly short period of time, again, about 6 months. And if we look here with regards to tolicizumab versus anti-TNF, it does seem to give you a better response with regards to CME, and the risk of relapse, though, is about the same in both groups. However, with regards to the reduction in the use of steroids, there is really no difference between the two medications. So it's really the tolerance and availability of the drug should determine your approach. The best drug probably to try and control edema, and it does so very quickly, is interferon. And here is a relatively old study now from 2013 using interferon beta. And what you see is that you get very quick and sustained reduction if you're using interferon. Much less the case if you're going to use methotrexate. In fact, there's a benefit in switching over to interferon in terms of both the visual acuity and also the reduction in central macular thickness. However, there are some side effects. The major one is, of course, the flu-like symptoms that are present. It is good at reducing the cystoid macular edema, maybe a little less so at reducing uveitis activity. So there seems to be a separation between the two effects in this case. And while depression might be a bit less with interferon 2 beta, it is certainly present with 2 alpha that also works very well. And both have to be started sub-Q 3 times a week initially, and can then be reduced to either an increased dose or later on to a slight reduction in dose. The flu-like symptoms can be dealt with by using paracetamol or Tylenol in the United States. And you also have to watch some of the blood parameters. And again, here, the results with regards to edema were very good. However, be aware that biologics sometimes can cause edema. And so if you're getting an idiosyncratic response, just make sure that it might not be due to that type of phenomenon. Now, in finishing, maybe it's worthwhile to just think about when should we choose one therapy or another. The first question is the inflammation still active? In late stages, you may have what appears to be macular edema due to RPE pump dysfunction, but you're not necessarily going to have improvement. And so biomarkers are important when you're looking at your OCT to make sure that there is something that would respond to your treatment potentially you could have a therapeutic trial just to see whether there's a response, given the parameters in which I've just told you that systemic therapy should work. Is 1 or 2 eyes involved? Usually if it's 1 eye, we tend to try and treat locally. If there are 2 eyes, we go more for systemic control. While if you don't have symmetricity, you might try to be able to reduce the inflammation and cystoid macular edema in both eyes by using a systemic approach, and whatever is left over in 1 eye is then treated with local treatment. Consider prior or current response to treatment and adjust the dose appropriately. It's important to know what they've received in the past and how well they responded. And also macular edema is most likely not the only person's problem. They may have glaucoma, they may have already cataracts, there may be diabetes present, which would orient the type of treatment you would use. And of course, be sure that your patient will be able to attend visits and have necessary controls. And if they're steroid responders, you'd want to be able to avoid this altogether. Thank you.
An excellent talk, Mark. Very practical points we'll come to in the discussion. It's my pleasure to introduce my colleague and friend, Dr. Stephen Ye, who is the Stanley Trulson Endowed Chair and Director of the Retina and Uveitis Service at the University of Nebraska, who will be talking about managing inflammatory macular edema with local therapy. Stephen.
Great, thanks, Prithvi, for the introduction. And also thank you, Professor Neri, for moderating the session as well as the program organizers. So I'll be speaking on managing inflammatory macular edema. Mark did a very nice job of talking about systemic therapies, and we're going to look at the other side of the coin, looking at the advantages and disadvantages of local therapies as well. These are my financial disclosures. So in the way of objectives, I'll talk about some of the tailored treatments for uveitic macular edema based on mechanisms as well as key targets, and really try to bring some of these concepts together related to the benefits and limitations of local therapies for uveitic macular edema. We're fortunate in the field to have large-scale randomized trials looking at some of these therapies at this time. We've talked about macular edema as the leading cause of vision loss in uveitis. One thing I'd like to point out is that macular edema can be observed with all anatomic subtypes of uveitis, including anterior, intermediate, posterior, and panuveitis. And as Mark nicely alluded to, it really does involve a complex milieu of factors that needs to be considered, including the upregulation of pro-inflammatory cytokines. Dilraj mentioned some of the systemic anti-inflammatory medications that can be used, but long-term, you can have breakdown of the inner and outer blood retinal barrier that can be indicative of disease chronicity that will also require really more assertive medications. Again, there are a number of therapies that are available, both systemic and local therapies that we often use in our clinical practice. And these can be very difficult to decide on. Which hammer do you use? How do you decide? You can see that there's a rock hammer, there's a reflex hammer, and then there's a sledgehammer. You have to figure out which one that you can use to balance these side effects as well as the efficacy profile. Certainly topical corticosteroids can be used in some situations, but we have to watch for steroid responders. And oftentimes, especially with posterior and panuveitis, you really need medications that go more posteriorly to exert the desired effect. It's important to recognize that with local therapies, and you really can't overstate the importance of recognizing that when a patient may have infectious disease, these are more obvious. This case of toxoplasmosis, another case of tuberculosis-associated uveitis. You certainly wouldn't want to use corticosteroids as primary therapy, but sometimes you can have presumptive cases or uncertain cases, and you really want to avoid local corticosteroids because of exacerbations that we can see. In addition, when we think about just the overall patient disease, if a patient has systemic disease, sarcoidosis, other conditions like Behçet's disease, oftentimes we will think about managing their systemic immunosuppression in conjunction with local therapies where needed. And I like to emphasize the importance of identifying the anatomical location, because this oftentimes determines the pharmacokinetics of medication that you'll want to think about related to anterior, intermediate, and posterior or panuveitis with regards to corticosteroid or other anti-inflammatory effects and medication penetration. So as I mentioned before, there are a number of local corticosteroid options. This is just an overview cartoon summary of the various clinical trials that have been published over the past decade and a half, which really have given us, again, level 1 evidence related to these therapies and how we utilize these in clinical practice. And I'll just walk us through some of these as we think about these therapies in clinical practice. Dr. Dunn talked about the multi-center uveitis steroid treatment trial, which compared systemic medications versus local intravitreal fluocinolone acetonide surgical implant for the treatment of non-infectious uveitis. And the primary outcome was a 2-year outcome for comparing looking at visual acuity as well as inflammatory outcomes with regards to systemic and this local corticosteroid implant. And just to summarize, and this was over a decade ago, but it showed that the visual acuity improvements were comparable between systemic immunosuppression as well as the locally administered or the local surgical implant. But interestingly, when you look at the local effect, the residual active inflammation metrics actually favored the local corticosteroid implant versus systemic immunosuppression. And we see this recapitulated in the macular edema outcomes that I'll get to as well. But you also need to recognize that with local corticosteroid delivery, again, this is a long-term 3-year implant, there was a higher rate of cataract requiring surgery, as well as a higher rate of patients who needed filtration surgery in the implant group. Now, what about the important metric, which is macular edema? It turns out that we looked at 2-year macular edema outcomes. At baseline, there was a fair number of patients in both groups, again, that had macular edema. Again, this is the leading cause of vision loss. But at 2 years of follow-up, 62% of patients who were in the systemic immunosuppressive arm required some local corticosteroid or regional corticosteroid adjunctive therapy, whereas this was far lower in the individuals who had the local corticosteroid implant. In terms of efficacy and safety, there were no differences in the groups, but with regards to macular edema outcomes by OCT, it actually favored implant versus the systemic group. The mean letter improvement was about 5 letters in both groups. Now, the dexamethasone intravitreal implant, or Ozurdex, the primary outcome was Vitrous Hayes score of 0 at week 8, and nearly 50% of individuals who received the current dose of intravitreal dexamethasone, or 700 micrograms, showed a Vitrous Hayes score of 0, compared to 12% of sham patients, and we see this reflected in macular edema outcomes as well. This was a shorter term study. This was a 6-month outcome, so there was a favorable low rate of cataract that was observed across groups. But what I wanted to emphasize is that this really set the stage for this NIH-funded trial that looked at periocular versus intravitreal corticosteroids, looking at periocular triamcinolone acetonide versus intravitreal triamcinolone acetonide versus intravitreal dexamethasone, or Ozurdex. And what we found was that the intravitreal preparations of corticosteroid, both the intravitreal triamcinolone and intravitreal Ozurdex, actually performed better from the standpoint of macular edema and visual outcomes when compared to periocular corticosteroid injections. It's notable, however, there was about a 2-fold increased relative risk of IOP elevation in patients receiving intravitreal therapies. And it's important to remember from a patient counseling standpoint, but again, patients do value their improvements in the vision, and so this is what I use for patient counseling. Moving on to the fluocinolone acetonide intravitreal microinsert, again, I would distinguish this from the surgical implant. There are 2 multi-centered RCTs that looked at the fluocinolone acetonide implant versus sham therapy. The primary endpoint in these trials were the proportion of patients requiring rescue therapy for inflammatory signs and uveitis. And so the primary outcome wasn't a macular edema, but it turns out that the recurrence rates were reduced in the patients who received local corticosteroid therapy compared to sham. You can see the significant difference in groups, and this was reflected in the macular edema outcomes with improvements in BCVA as well as macular edema in the fluocinolone acetonide groups. And you can see the divergence of the curves here. And lastly, we have exciting technology related to suprachoroidal corticosteroid injection, which gives high levels of drug within the retina of the choroid. And the Peachtree study was a phase 3 study that looked at suprachoroidal corticosteroid injection given at day 0 and week 12 versus sham control therapy, with a primary readout at week 24 of best corrected visual acuity. And when patients received suprachoroidal corticosteroid injection, they had a far greater likelihood of improving visual acuity, with 47% improving by 3 lines or greater compared to 16% of individuals in control. And you can see the time curves with about a 10-letter improvement at week 4, proceeding to about 14 letters at week 24. And this is a case that brings everything together. This is a 58-year-old patient with clinical evidence of Birdshot, was HLA-A29 positive and bilateral cystoid macular edema. And this patient was treated with combination of therapies with both systemic methotrexate as well as initially subtenon's Kenalog. Ultimately, the subtenon's Kenalog didn't improve his macular edema, required intravitreal therapies with a very nice improvement, still some residual cysts. Eventually needed additional therapy and had suprachoroidal drug delivery both in the right and the left eyes. You can see the nice result with still some subretinal fluid that's remaining, and we sometimes will see a delayed response with suprachoroidal drug delivery. But again, fully utilizing the armamentarium of both systemic and local therapies. And so again, it's important to use a tailored approach ultimately with regards to these metrics and this data. This is important as we assess these therapies to improve the quality of life for our uveitis patients. Thank you very much.
Thank you, Stephen, for this beautiful presentation. Not surprised that you made a point, and it's going to be great to have your opinion later on during the discussion. Thank you again. It's now my great pleasure to introduce my colleague and friend, Dr. Anirudh Agarwal, who's a vitreoretinal consultant for Cleveland Clinic Abu Dhabi and also uveitis consultant, who's going to talk about any role of combination therapy for inflammation macular edema. Thank you, Anirudh.
Hello, everyone, and thank you very much, the team Innovate Retina, for this kind opportunity. And so I'm going to be the good guy today and talk to you about how you can combine both systemic and local therapy for uveitic macular edema. So we've heard about a lot about the advantages and disadvantages of both the therapies, but I would like to start when not to use local therapy so that we are very clear which cases we are really selecting for a combination treatment. Of course, we don't use local therapies if you have a diagnostic uncertainty and in most of the infections. Now, we did talk about TB in the previous talks, and we believe that TB, certain manifestations of TB, such as serpiginous-like choroiditis, are really an autoimmune manifestation of the disease. And in patients with such conditions, you could use local corticosteroid implants. I also don't like to use local therapies if you have macular edema, but concomitant media, when the media clarity is not good, for example, a dense cataract, where there is a severe vitritis and you don't have a sufficient view of the retina. Of course, there are other indications where you have exudative detachments or choroidal detachments, things are unknown, or you have obvious contraindications like high IOP. But this is a small subset of patients really, and you have a large subset of patients who could benefit with a combination. So we know that, like Dr. Ye mentioned, and in the previous talks, we've heard that macular edema is quite common, and Mark Dismet as well. He mentioned that all the phenotypes of uveitis could have new onset CME despite adequate immunosuppression. So you could have CME with local factors playing an important role, and we have talked about interleukins in the previous talks. Now, I think MUST trial is something that we all have talked about. But even in the MUST trial, I just want to highlight this one fact that in the MUST trial, which was done several years ago, there was a combination of systemic on one side versus the intravitreal Retisert implant, which we don't use, the surgical implant anymore. And there have been publications after that which have differed from the MUST trial and have pointed out the weaknesses of the MUST trial. And we know that now the MUST trial itself has certain limitations in the sense the re-injection was not predetermined. The implant was equally effective for patients who could tolerate the systemic treatment. And the study was not designed to really evaluate the outcomes as long as it's 7 years. And now we have many new implants, new devices, like you have the new intravitreal fluocinolone, dexamethasone, suprachoroidal. And so you have several options available to us right now. One of the options that we all keep in mind when we have patients in a clinic is how to optimally combine the two strategies of systemic and local, trying to avoid the systemic or local adverse events as much as possible. Now, of course, you have certain advantages of local treatment, and I feel that with local treatment, you get a very predictable response. Systemic treatment could be insufficient at times, may not be tolerated. You may have practical limitations, such as you could have an overweight patient, a diabetic patient, a patient who does not tolerate systemic steroids. So with local, you could have a faster response, whereas systemic treatment could take some time to act. And now you have a wide choice of agents. And of course, you have steroid sparing effects, and you're trying to avoid all these systemic effects, which we all know about. Adalimumab is, I think, very commonly used in non-infectious uveitis, has a lot of data supporting the systemic use. And I think you could easily combine local therapies with adalimumab to have sustained improvement in these patients with macular edema. We are really waiting for the results of the MERIT trial, in which we have 3 arms, where we are comparing the safety and efficacy of methotrexate, ranibizumab, and dexamethasone implant. And remember, the MERIT trial is designed such that the patients could have sustained immunosuppression at a stable dose. And MERIT is a parallel design randomized controlled trial. And I think this could give us very good evidence of how you could optimally combine systemic and local immunosuppression in these patients. Besides CME, you have a lot of advantages of local therapies, and we have a lot of patients where you could have choroiditis, could be a garden variety of choroiditis or even tubercular, and you could have patients with retinal vasculitis, vitritis, where you have a very good resolution. In patients with suboptimal response at the initiation of therapy or during the course of therapy when you have flare-ups, I think local therapies have a very important role. And there are specific conditions where you have, for example, immune recovery uveitis, or sometimes you have post-infectious inflammation, such as in post-viral uveitis, where you have macular edema. I think these are very specific indications where even short-acting local therapies, such as intravitreal methotrexate, could be used with very good results. We've talked about safety and IOP and cataracts in the previous talks, and the advantage of local treatment now with so much experience from all of us using these agents is we know what to expect, which are the patients who could have a high IOP and cataracts. And I think as uveitis specialists, cataracts probably are not much of a concern, but IOP is, but we do know what we are expecting when we are injecting. So again, you have this situation where you have a patient with birdshot, typical lesions. There's a lot of leakage, but there are practical considerations, such as certain that I mentioned already. So you have a high body weight, patient is diabetic, you may not be able to start the patient on steroids or continue for a very long time. And these are patients who are ideally suited for local therapies, especially if they have macular edema. And you have some alterations coming up on the structure as well. So in these patients, when you combine with local treatment, you can see you have a fast response. There is a good or an adequate control with local therapy in these patients. I would also like to show you certain patients where you have intermediate uveitis, and you could have a response, very good response to Ozurdex, and I think Ozurdex plays a very important role, especially in unilateral intermediate uveitis. You have a very good sustained response. Certain patients with intermediate uveitis, if you repeat fluorescein after local treatments, you have a dramatic response in terms of leakage and disc edema. So you could also have certain advantages such as TB, and we have a lot of experience with using local therapies in TB. And we realize that intravitreal implants in combination with systemic treatments when given could reduce the incidence of paradoxical worsening or even control the incidence of paradoxical lesions. And they could limit these vision-threatening lesions which come straight into the foveal center. So you could have patients with macular choroiditis lesions, and now I have started to use often in these patients a combination with either intravitreal methotrexate or Ozurdex with systemic agents. We add TB drugs as and when necessary, and we really get a very good response with minimum changes on the autofluorescence and in the RPE. So you see, within 4 weeks, the patient could be potentially off systemic steroids. So this patient was completely off systemic steroids with the intravitreal adjuvants. And you could have total prevention of the RPE and other alterations in these patients. And you can see these on the OCT angiography. You have a very good resolution, and you see that there is hardly any alteration of the choriocapillaries. And these patients do not tend to have a lot of macular edema moving forth. So lesions which are very small, they tend to resolve with minimum flow voids. I think addition of local therapies early on could be very advantageous in these patients. So again, you have other patients, you have high body weight, systemic problems such as menorrhagia, hypertension, and you're limited. You can't use high dose corticosteroids. And in these patients, addition of intravitreal agents could have a rapid response, and you could have patients completely off steroids after a certain point of time. So, these agents, Ozurdex is one, but you have several options. They work very well in choriocapillaries recovery with reasonable adverse events. But of course, I would just like to remind you, rule out infections. But even in situations where you have post-infectious cystoid macular edema, you could potentially use intravitreal agents in these patients. So I'd just like to conclude by stating that combination has an important role. I think most of us in real life do use combinations. And I think this is an exciting area where you could potentially personalize treatments, improve patient outcomes, and reduce the dose of either systemic and local therapies, use them in an optimal way so that you have the best possible outcome with minimum side effects. Thank you very much once again. Thank you.
Thanks, Anirudh. We'll invite all of our speakers onto the panel, and I'd also like to introduce Dr. Christopher Orr, who is a colleague of ours here in the uveitis service here at the Byers Eye Institute at Stanford. So I'll hand it over to Pier Giorgio to start off the panel.
Thanks very much. I mean, I have a question for the first speaker, Mark. How do you feel, Mark, that systemic therapy may represent an advantage compared to the local therapy for inflammatory macular edema?
So with regards to systemic therapy, if it's bilateral disease, I think it indicates that you're not just dealing with there's a large systemic component. So having systemic medication, I think, makes sense. And also in the examples that were shown, for example, with birdshot, we can take care of the local problem, but we also have a choroiditis that we have to deal with, and our edema is more of a retinal problem. So I think that for certain diseases, we need systemic therapy for a control of the immune system. And with regards to the edema, if we're not doing a good enough job with our systemic therapy, then we need local therapy. That's the way I look at it generally.
To add to that, Anirudh, as a retina specialist, I'm very comfortable with injecting steroids into and around the eye, but I may be very uncomfortable with using systemic therapies. And as Mark pointed out, there's a time and a place for both. Other than starting a patient on oral prednisone, probably at a subtherapeutic dose, as most of our retina colleagues are bound to do, like I'm bound to do. What are some guidelines in terms of taking that next step for systemic therapy for just macular edema?
Well, if you're asking me, sorry, go ahead.
So in my practice, I rarely start oral corticosteroids above a dose of 60 milligrams or maximum of 70 milligrams. It makes me uncomfortable. And if I have, like Dr. Desmet, he pointed out, if you have a bilateral disease, I could be, very comfortable in starting an oral dose for macular edema itself. But if it's a unilateral case, I do feel uncomfortable. And I always look for any concomitant inflammatory lesions. And if it is a patient who has just a unilateral, for example, an intermediate uveitis, I would just go ahead with local therapy. And I feel comfortable injecting steroids in those patients. And usually you get a very good response. So I think it just depends. Laterality does play a role. You have, of course, the other inflammatory markers apart from macular edema, they play a role. So I think you have to kind of pick and choose what you will start off with.
Yeah, so maybe just, I'll just add one point is that, yes, you can start with up to 60 milligrams per day. I think it's a good way, but if you're not able to reduce that dose within about 2 months, you better refer and get somebody to have a look at it, because we have to get the steroid dose down. And that means we have to go to alternatives.
And I would just add that when in my practice, that it really is a conversation with the patient to talk about the various regimens, both systemic and local. And sometimes we'll know what the patient will accept or not accept based on their reaction to where, I mean, and I agree with Anuradha that I feel comfortable when I'm escalating the dose over 60. We think about a 1 milligram per kilogram dose, but sometimes that can be 80 or 100 milligrams. And then with regards to some of Mark's very nice slides about IV corticosteroids, I mean, if they really have severe acute sight-threatening disease, we're going to head that direction. And to Prithvi's comment about macular edema, I think that just watching the macular edema, how it responds initially, really is very telling in terms of, I think, how it will respond and then be maintained if we decide to switch over to systemic immunosuppression. And there's multiple factors to consider. And I really think it's a conversation between the physician and the patient with regards to decision making.
Yeah, so thank you very much, Steve, for addressing that. And I will ask you a question, but I would like also to make a comment. It's important, and Mark has pointed out the 60 milligrams. It's the American College of Rheumatologists has pointed out that if we go above that, we can have the septic necrosis over the hips. So that's very dangerous. And we used to treat patients with 1 milligram per kilo, reaching, levels of even 80 milligrams for longer. And that was very, very, very dangerous for the patient. And I think this is an important concept that, came out after many studies and many years. I have a question for you, Stephen. I mean, you pointed out that there are these new techniques, particularly the suprachoroidal space that is, really fascinating. And, I started, doing the orbit absorbers or the subtenuants that are my favorites. And now we have the approach for the intravitreal ones. Do you believe that, there would be a space where suprachoroidal space approach might be the real deal, particularly for the unilateral ones with a very high level of severity, or when you have an asymmetry between the two eyes? What do you think about that?
Yeah, that's a great question. And I talked a little bit very briefly on the pharmacokinetics of high levels of drug within the retina and the choroid with suprachoroidal drug delivery. I mean, when you compare it in animal studies, there's about a 10 to 12-fold increased ratio of retina choroid versus anterior segment versus intravitreal. So I think particularly for individuals with a high level of choroidal inflammation, birdshot, VKH, I think about this as a potential, really a game changer for these types of patients. But I think, again, there's a learning curve that's associated with it. We're very comfortable with intravitreals. I think they work very well also, but I think that there is a space as we think about suprachoroidal drug delivery moving forward versus, in addition to the other therapeutics that we use in clinical practice.
Chris, when we do vitrectomies, we will sometimes have, a good macular peel, but then there's still persistent post surgery macular edema. And I don't know whether to call that, uveitis, or is it just, a function of vascular instability. I may or may not get a fluorescein. The disc may not be leaking, so it may not be classic. And I'll usually start them on non-steroidals and steroids and just watch that for a long time. How does the uveitis world look at that as an entity, and then what are our options for post surgical CME after retinal surgery?
Yeah, absolutely. That's a great question. And so I think on probably post-surgical macular edema probably falls within the spectrum of the retinal diseases that causes macular edema. And a lot of times I utilize a very similar approach to different kind of uveitic macular edemas when I go ahead and see the diagnostic approaches or even therapeutic approaches to them. Certainly with vitrectomy, you're already removing the inflammatory load if there are any inflammation there. But the actual surgery itself likely probably instigated some inflammatory responses within the eye. And sometimes I use local or combination with systemic therapies to hopefully get the macular edema under control. And certainly there are lots of different studies that are looking into different options for post-surgical macular edema as well. And we're trying to start a study here at Stanford looking at topical drops to see whether or not that could be an option to treat post-surgical macular edema. But those can be very difficult to control at times. But my approach to it, I'm not sure if the panelists will agree. And my approach to it is very similar to different type of uveitic macular edemas that are non-infectious. And my treatment approach is likely similar as well.
Well, I think we have to look at whether...
I'll add just one comment to, maybe you can comment, is what do you code post-surgical macular edema as if I want to get certain therapeutics on label approved? But I'll wait for your comments.
Well, I think for the code, you have to see what you use in the US because we don't have the same codes when we're in Europe. I think you have to look at whether it's post-cataract. If the cataract was done at the same time, I think, it's very often a nerve and gas type of situation. That's inflammatory. In what you described with the peel, it could be inflammatory, but you also have the situation where if you remove the ILM, you're in fact removing some of the foot plates of your Mueller cells, and your edema looks different. It's very persistent. It responds to steroids, but I don't think it's inflammatory. It's partly damage to the Mueller cells. And, over years now, we've seen several reports that suggest that it's up to 10% of peels with an ILM peel that ends up causing this problem. And there, I've treated some patients for up to 3 years with intravitreal Osidex, and that's the only thing that controls the edema, but I see no inflammation. There's nothing on the OCT to suggest that it's inflammatory.
Guys, oh, sorry, please go ahead.
Yeah, so after surgery, there's a certain amount of inflammation, and so I don't think it is out of the realm of possibility to quote that under the uveitis world. If you want to give it a code there.
So guys, I wish to go a little bit, outside, the standards, but I want to have like, quick fire question, for every one of you, for Ani, for Steve, for Chris, and for Mark. So I published, quite a while ago, a little pilot trial about, the efficacy of mycophenolate mofetil as the elective kind of immune suppressant for addressing the problem of persistent cystoid macular edema. It was a very long time back. Question for you, do you have any kind of drug that you among the standard immunosuppressive agents that might be the one that you would like to choose when you have to deal for a chronic macular edema, or if yes, which, and if not, why? Aniruddha, if you want to start.
So I would go with mycophenolate or azathioprine. I think these are very conventional agents. They work well with macular edema. Methotrexate, not so much. Systemic.
Sure. Steve?
Yeah, I mean, I feel like the TNF alpha blockers just give like very nice long-term control now, and so I think I would go with the TNF alpha blocker adalimumab. But mycophenolate I think is a great option.
No, but the question was for the traditional ones, since, I mean, sometimes, even for insurance perspective, I mean, the insurance company are not very happy that you go straight away.
Yeah.
If you have persistent, you don't have, much evident blood-retinal barrier impairment, and you see just a persistent cystoid macular edema, you don't want to go extra mile for the patient. Which one would you choose?
Yeah, so I would say younger patient, mycophenolate, elderly patient, methotrexate.
Methotrexate. Chris, what about you?
And so I prefer mycophenolate to just ease of use. And in the fast trial, I mean, it's been presented already. I mean, I think some of the macular edema results are better with mycophenolate in that group. And so I prefer mycophenolate in this kind of patient population.
Great. And last but not least, Mark, what do you think about that?
I use mycophenolate also, and if that doesn't work, I try to go quickly over to a biologic, and then it would probably be an anti-TNF. And if interferon becomes again better available than it is right now, I'd go to interferon for younger patients.
Mark, since you addressed about that, about interferon, we have evidences that also interferon beta can work. Do you have any experience about the PEG one that is, the one available now in the market, and you can utilize that, but do you have any kind of direct experience on that? Because, the traditional ones are not available anymore, but PEG is available. Which one, do you believe that is the same?
I haven't used it, but the publications I've seen certainly suggest that it works in the same way. And for other indications, it may even have a more prolonged action. So yes, I think that would be the way to go, is to use the pegylated form. Pegylation just helps to prolong the activity. So we may have to modify the dose.
We hear about side effects, and my next patient that I see in clinic doesn't have the side effect, and I'm suddenly very comfortable with the therapeutic. So looking at the various options that we have available, what are your thresholds or your recommendations for thresholds in terms of side effects with multiple dosing of intravitreal or sustained release therapies, and maybe Stephen, with multiple suprachoroidal injections? Is that effect not as much in the real world as we see in the clinical trials?
I mean, I think that I think along the lines of clinical trials, we think about DLTs or dose limiting toxicities. Interestingly, when we think about locals, I find that when we talk to our glaucoma colleagues, that they say, go ahead and treat the disease and we'll treat anything that comes up. I found that with these shorter acting therapeutics like intravitreal Ozurdex or suprachoroidal drug delivery, having to have a filter is not common that I've seen in clinical practice versus Retisert, where it's very common. So I think that I generally will treat locally, and I don't have a threshold. I think that if they're uncomfortable with the therapies or they want to go systemic, then that's probably more my dose limiting than something locally, at least with the shorter acting agents.
Anirudh, any comments?
Yeah, I agree. I don't think for me, usually I'm very comfortable if the glaucoma specialist is confident in managing the pressures. I have very few patients who required surgery after multiple dosing. So most of the times I do agree it's the patient who refuses intravitreals or local therapies, but I generally persist with it. I often combine it with vitrectomy. There was a comment on post-vitrectomy macular edema. So in patients where you could have, for example, an epiretinal membrane with a lot of macular edema, I often go ahead, do the vitrectomy and inject, for example. And I think I get a good response, a sustained response. And difluprednate does work very well in those patients post-op.
Yeah, Prithvi, I guess the one comment I would make is that in a vitrectomized eye or somebody with a broken capsule or an open capsule, then I do avoid some of the intravitreal therapy just because of that slight concern for anterior chamber migration.
You find that glaucoma MIGS procedures now is an alternative to putting a filter or a tube in these patients? Any data that you can tell us about, Mark?
With regards to the using the MIGS, they work, but if you have an acute situation with very acute glaucoma and you're going to treat, let's say, with something intravitreally, your MIGS is going to fail. That you have to accept. But if it's done during a period of quiescence, what I've seen so far in my own experience and that which from speaking to colleagues, the results have been very good. I mean, there's no better situation than to do a glaucoma procedure than when you have lots of steroids on board. So once an eye is quiet and they have steroids, that's the time when you should put your MIGS or do your filtering procedure.
Professor Neary, we're ending the end of our panel. Any last comments from you?
Well, actually, I mean, I agree with you. And the only thing is that when you use the mix, the only problem is that you can have the problem for the drainage that can be occluded. So in that case, you need to be very sure that you're doing the right thing even locally. Sometimes even utilizing difluprednate after the surgery can help. I have just a rapid fire question for them, if I may, just very quickly about the monoclonal antibodies. Very rapidly to each one of you, starting from Mark and going back, to the others. When do you believe that monoclonal antibodies should be used immediately, apart Behçet disease that is undisputed, and in some cases you have to go right away? Which is the scenario that you would consider the ideal one for that? Mark first, and then Chris, Steve, and Aniruddha.
It depends on when a person shows up with VKH. I usually start with steroids, but very often if there's a sign of chronicity when they present, you might as well go to biologics right away. Birdshot is also a condition where I go quickly to biologics because I think you need long-term therapy and they're better off with that.
Excellent. Christopher, thank you.
Yeah, and so I'm trying to think to see if there's a condition that I will go straight for biologics, and I don't think there's one where I would treat it as my first line therapy. A lot of times we use anything else, even if it's very aggressive disease. A lot of times I start with probably intravenous methylpred and kind of see the response to that. But I mean, I agree with Mark's point. Like if you have someone with very severe disease that they're going to need combination therapy, otherwise, it's probably not a bad idea to start that as well.
Excellent. Steve, what about you?
Birdshot, VKH, and vision-threatening JIA.
Vision-threatening JIA. That's excellent. And Aniruddha, you're the last but not least.
Behçet's, birdshot, and bad GIA. I agree.
So I think that we have an agreement, guys. That's awesome. So I think that the time is over now. And, I just want to thank you very much for the awesome job. And it's now time to move to the last session. And thanks again for taking part to it. Thank you.
Thank you.
Thank you.
So at this time, we're moving to the non-CE section of the agenda. And this is entitled Innovation for Pharmaceutical Companies to Invest in Studies to Evaluate Ocular Inflammation. If you look at your screen, you're in the general session. If you go below, you will see a place to point for a video box to join us for session 4. If you'll please go there, and we'll join you on that side. We have 2 video presentations. One is by our corporate sponsors at Genentech and Regeneron.
Waar, Bais, Mau. The Bais Mau.
Hello, I'm Kevin Clark, Vice President, Ophthalmology at Regeneron. For nearly 35 years, Regeneron has used the power of science to bring new medicines to patients. Our scientists build the medicines of tomorrow, marrying cutting-edge technology and biology to revolutionize how we target and treat serious diseases. At the heart of our science is a commitment to developing life-changing medicines for people who need them. Our ophthalmology franchise is the manifestation of our work towards that commitment. But we're not done. Scientists and researchers in our ophthalmology franchise continue to explore a broad range of therapeutic areas with a long-term focus on discovering and developing additional important medicines. At Regeneron, we follow the science to solve the human body's most complex mysteries. From our rapid response efforts to infectious disease to the complex world of oncology, we've invented new technologies and pioneered novel approaches to revolutionize how we make medicine. I'm incredibly proud to work at a company who is continuing to innovate clinically and in new ways to support both patients and the retina community.
All right, so welcome to section 4. I'm pleased to introduce this section. We're going to be talking about innovation for pharmaceutical companies to invest in studies to evaluate ocular inflammation. And leading off section 4 is my colleague, Dr. Mark Dacey. He's the director of the uveitis service at Colorado Retina Associates in Denver, Colorado. Dr. Dacey is also the co-chair of the subspecialty committee of the Retina Consultants of America. He's been involved in numerous uveitis and retina clinical trials, and he'll be giving a talk titled Inclusion and Exclusion Criteria for Clinical Trials that are Enrollable and Retainable. Dr. Dacey, please take it away.
Thank you, Stephen, and thank you, Quan, for inviting me to speak with you all today. It's an honor to be participating with such a group. So my financial disclosure, there's no conflicts with any of the material I'm presenting. So inclusion and exclusion criteria for uveitis studies have really evolved considerably over the last decade. Historically, we had two major inclusion criteria and outcomes. We looked at anterior chamber cells and vitreous haze using the NEI and SUN criteria that Bob Newsom-Blatt developed back in the late 80s. And you can see the diagram here using looking at vitreous haze, and this was used to obtain FDA approval for Retisert back in 2000. And it was the basis for the Huron study that led to Ozurdex approval a decade later in 2010. In the mid-2010s, there was a considerable tipping point and a change in how we approached uveitis studies, and that came from the Visual 1, 2, and 3 adalimumab studies. And there were two major paradigm shifts that were introduced at the time. The first was introducing this new concept of a time to treatment failure study. This was the first of its kind in ophthalmology, and now it's been mimicked in a number of the presentations that you heard earlier. And then it also introduced a new inclusion criteria of at least one active inflammatory chorioretinal or retinal vascular lesion, which really changed the amount of patients that were able to enroll in uveitis studies. So we'll go into both of these in a little bit of detail. First, the time to treatment failure. This is, as Quan and many others have presented over the years, systemic immunomodulatory therapy is really the gold standard in the prevention of flares of non-infectious intermediate posterior and pan uveitis. And so the model for this study is that patients usually present with active inflammation, some combination of anterior chamber cells, vitreous haze, and these inflammatory chorioretinal or vascular lesions. And then they initially receive a burst of high-dose prednisone with a subsequent 2-month taper. But at the same time, they're also started on preventative immunomodulatory therapy, which on average takes about two months to become therapeutic. And then they're monitored for time to recurrence. The other paradigm shift was including these inflammatory chorioretinal or vascular lesions. So this was really an important shift about 8 or 9 years ago in uveitis studies, because most of the studies up until that point had required 2+ vitreous haze or greater, and that's very challenging to find. Most patients don't wait that long for their vision to get bad enough to warrant 2+ vitreous haze. And so in a number of patients, you can still have a fair amount of active uveitis in the absence of vitreous haze. This is a good example of a birdshot patient who has maybe trace to 1+ haze, but significantly active retinal vasculitis. So you would argue that their uveitis is still significantly active, but they don't meet the vitreous haze requirements that were necessary for some of the prior studies. And this has allowed us to expand the potential pool for patient recruitment substantially. So we still use vitreous haze to a certain extent, but it's not the end-all be-all, and it's certainly not the sole barometer for these studies any longer. So looking at inclusion criteria in a little bit more detail, these are fairly standardized for non-infectious intermediate posterior and pan-uveitis. It's usually defined as at least 2+ anterior chamber cells, at least 2+ vitreous haze, with the addition of or inflammatory chorioretinal or retinal vascular lesions. And this can be defined in any way. It can be just visible on a fluorescein angiogram. You can see it on clinical exam or OCT or fundus photography. In a lot of the studies previously, there's been a prednisone requirement, a stable dose of either 7.5 to 10, up to 40 milligrams a day for at least 14 days prior to randomization. And that really added another challenge to enrollment, because if you have someone with 2+ vitreous haze, but then you have to put them on 10 of prednisone for a couple of weeks, that really diminishes the chance of having severe enough disease to merit enrollment. So one recent development we've seen is that several studies have actually waived the inclusion criteria for prednisone, which has eliminated another barrier to enrollment. The prednisone requirement also can disqualify some patients, obvious ones like brittle diabetics or severe steroid responders. But in my experience, the largest factor is patients who just don't want to be on prednisone anymore. You can outline the entire study. They say, that sounds wonderful. And then you mention, oh, by the way, we're going to put you on high-dose prednisone for a couple of weeks with a taper over 2 months. And they go, no, I don't, anything but prednisone, as long as I don't have to do that anymore. So despite waiving the initial requirement, sometimes we still have to put patients on prednisone, and that can be a barrier to enrollment. In terms of exclusion criteria, these are also fairly standardized across uveitis studies. Obviously, you have to exclude infections and masquerade syndromes, various mitigating factors. There's standard washout periods for different types of injectable steroids and biologic immunosuppressants. But traditional immunosuppression, methotrexate, CellCept, cyclosporin, is typically permitted. In general, anti-VEGF injections are also prohibited, and that perhaps in the future could be an option for some patients. For example, I had a 30-year-old who's currently in one of the immunomodulatory therapy studies. He has chronic pars planitis in both eyes, and his inflammation is doing beautifully on the study drug. He has no active disease, but he has a little bit of chronic CME that recurs, and it's highly symptomatic. And in most of these studies, there's no provision to treat CME with a medication that won't affect the evaluation of their inflammation. So unfortunately, this patient had to be rescued despite not having any active uveitis. So I think investigating provisos or ways that we might be able to still manage a small amount of cystoid macular edema could prove beneficial as well. So as a number of other speakers have alluded to, this is really a golden age for uveitis studies. This is just what's going on in our practice, but we have 3 time to treatment failure studies that are ongoing. There's an intravitreal injection for uveitic cystoid macular edema, and we just completed an anterior uveitis trial using a non-steroidal medication. The reason that I mention these is that for those of you in retina practices in the audience, there is a motivation to do these smaller uveitis studies in that they often lead to larger scale retinal studies. So historically, pharma has started by studying a drug for uveitis in general because there's less patients required for FDA approval. And then those go on to study wet AMD and diabetic macular edema. So this is a model that's been followed for Ozurdex. It was approved in 2010 for uveitis, but it took 5 more years to get approval for DME. The port delivery system was originally a methotrexate study that worked so well that patients had non-healing epithelial defects on their cornea. It went on to achieve FDA approval for wet AMD 2 years ago. And similarly, YUTIQ and XIPERE have now tried to use this model for uveitis and for uveitic macular edema to get their approvals, and parlay that into studies now ongoing for wet AMD. So I'd like to thank Quan for inviting me to speak with you all on the uveitis team at Colorado Retina, and I'll show you a couple of my favorite places within Colorado. But thank you very much for your attention.
Thanks so much, Dr. Dacey. So we're now going to be moving to our second and final talk for this session. And pleased to introduce Dr. Player. Dr. Player is one of the leading uveitis specialists in the world, well respected by colleagues in the field of uveitis. He's been involved in many uveitis trials. He's also the Congress co-president of the upcoming 2023 International Ocular Inflammation Society Congress in Berlin, which is scheduled in September of this year. Dr. Player will be giving a talk titled Endpoints for Clinical Trials That Are Achievable and Approvable. Dr. Player, looking forward to hearing from you.
Hello.
Yep, we can hear you, Dr. Player. You could go ahead and turn your screen on and go ahead and share.
I'm sorry.
We can now see you very clearly. Go ahead, please.
Okay.
Great.
So good afternoon, and thank you for the kind invitation. I really enjoyed the meeting so far. I think it's really on the edge on uveitis science, and I'm really happy to be with you. And I just learned that the industry is also probably interested in this talk, and I certainly would try to give a kind of easy introduction to the endpoints that we have in uveitis. So the challenge certainly is that we do have a burden on uveitis disability in the population. So the younger patients in particular are affected. And unfortunately, uveitis is not in uveitis. So uveitis is a broad umbrella of different entities, which makes it difficult to differentiate the endpoints for each of these different diseases. And so far, unfortunately, I have to say, and this will be another target for my talk, measures have been mainly based on subjective findings, and it has been just nicely introduced that the Sun classification and the criteria which come back from the 1985 years are still effective, and I think they worked, but still we have to search for more objective findings, and therefore I think the effort in the next decade is certainly to have better and more reliable outcome measures. So the solutions and the questions that we have to raise are which parameters are so far amenable to quantify the analysis, and just a few illustrations are on the back, and which parameters have been successfully so far, so we probably can rely on these. And of course, in the future, on what possibilities can we probably count future studies? And I think the effort has been in the last decade already started. Still, we don't have, I have to say, the right solution. So an easy part might be, and it might be even too simple, to have an endpoint regarding visual acuity, which seems to be not a good endpoint. Since first, it's subjective, the patient has to report. But still, I think it's very important to motivate your patient. And therefore, if you have an endpoint which includes all the visual acuity, you may have a better response in recruiting your patient, since you can tell we will measure your vision over the time. And this has been, of course, used in many trials already. And you can see that most of these studies have been probably focusing on macular edema, which probably gives the best benefit in our patients, and therefore I think it's smart to have this kind of endpoint included in these presentations. Coming from the front part of the eye, the anterior chamber, which is easily available for us, is another very important, and I think in the composite outcome measures, also reliable part. We do know that there is some inter-observer variability, but still 0.8 coefficient is probably enough to have this as an integrated part of an composite outcome measure. And this has been used, and this has been already mentioned in the visual studies, for example, but also in other studies using corticosteroids, for example. But this might be in the future also a place where we can have a more objective finding. And in OCT, you may be having difficulties to see the anterior chamber cells in the back part here. But this probably could be an option to have a more objective finding in clinical studies, at least in a composite score. This has been mentioned already, and I think this was from the FDA actually one of the most proven endpoint, the vitreous haze. And vitreous haze, as mentioned already, has been based on the Sun classification criteria back to Papenhausen. And still, I think it is a feature which is important and has been used successfully in the Huron study, for example, also in the visual study. Therefore, I think it's one parameter which probably will also persist in the future. Still, similar to the anterior segment, we may have more objective measurements regarding based on OCT, but also probably on photographs, which gives us a more reliable outcome measure regarding the density on vitreous haze. And you can see here an example where already some efforts have been done to quantify based on the vitreous haze and OCT measurements the inflammation. There are probably other features which are probably included in the OCT findings, which are so far not really approached. So chororetinal inflammation, and most of the studies that we are performing are on the posterior or intermediate uveitis, are also probably featuring a number of different features in different diseases. So macular edema, of course, is a very prominent finding, but also we have chororetinal infiltrates, vasculitis, and even optic nerve changes can be probably an outcome measure, since in the long term, this might be an effect which also has an endpoint character in future studies. So I want to point out a little bit more on these findings. And of course, central retinal thickness can be easily measured by OCT, and it has been, of course, in many studies focusing on macular edema, the primary endpoint, like in the ZenCat, which is still ongoing, but also in Illuvian and other studies focusing on macular edema, the central retinal thickness is certainly a point which is easy to measure and gives us a quantitative result. We have to be careful, however, since you may have atrophy, and if you have a burned out, let's say macular edema, then of course changes are limited, and I think the inclusion of patients is certainly based on the critical inclusion criteria, and therefore it is really important to mention this. So other findings are on the back part, for example, the dark dots, and you can see here in birdshot, for example, this could be in the reading center, certainly a readout, which so far has been not so far used frequently, is the autofluorescence. I would think that this is a non-invasive procedure which gives us some good results, and probably in the future, this could be another option to include as an endpoint. Regarding the vasculitis, there is some limitation, I have to say. So far, we have the traditional central part of the vasculitis in FAG. And I think that now with the wide field images, we have better approaches. Unfortunately, in many studies, the newer features are not really included. And I would think that we probably have to switch here gears. I talked about the composite endpoint outcome, and just to give you an example what this really means, here are the features which have been taken together as a composite outpoint, which is the visual acuity, intraocular inflammation, which could be anterior and posterior, central retinal thickness, and of course FRG, and also the steroid tapering modus, which has also, of course, an impact on the clinical design, on clinical endpoints in uveitis studies. We don't have to forget that also patient-reported outcome measures are important, and these are always required by authorities. And I would think that the quality of life certainly is what we want to have in our patients. So I think monitoring the self-reporting features is another important point. Just to conclude, a kind of critical summary. When we observed the last 100 studies, we can see that the efficacy outcome alone was on one single outcome only in about 1/3 of the studies. So in many studies, we have already composite outcomes. So I think this is probably the way to have a better outcome measure depending on the different types of uveitis that we are using in our clinical trials. And some recommendations, I think many studies or some studies have failed since they may have had too many treatment arms, two different dosing schedules, and therefore simplifying the treatment arms and the dosing is probably an important point. Also, the sample size is sometimes too small. I think in any study is certainly a critical point, and the outcome measures, just to make it short, certainly have to be more objective. So in summary, the directions that we have to go is we have to have future developments regarding reliable core outcome measures, which are probably better instrument-based, and measure should be done, I think, as optimal as possible. And of course, as was mentioned already, some of these points will certainly also be discussed at the IORS Congress, which will be in September. And you are cordially, of course, invited, and we hope we have a good and fruitful meeting.
Wonderful.
Thank you.
Thank you so much, Dr. Player, for that outstanding talk. I'm now pleased to introduce my co-moderator who needs no introduction, the one and only Dr. Kwon-Dong Nguyen, who is going to be introducing our panelists for this fourth and final panel on this morning. Dr. Nguyen.
Thank you, Stephen, and thank you everyone for joining us to the last panel here. I would like to introduce some of our other colleagues who are joining us. First and foremost, I'd like to introduce Dr. Sumit Sharma, who is a leading physician, clinician scientist at the Cleveland Clinics. Over the years, Sumit has been very well known for his work in uveitis conditions as well as in retinal diseases, and he's leading many trials already so far. Then we also have back with us some of our colleagues who've been just presenting with us. And in addition, we are joined today by several leaders in industry. And let me first start to introduce Dr. Yang Chiang. He himself is the Chief Medical Officer at Tourmaline, and he has extensive experience in trial work as well. And Yang and Tourmaline are leading several clinical trials right now. We then have Dr. Michelle Stone, who is the Chief Scientific Officer at Ocular Therapeutics, located in the Bay Area. Michelle, with her extensive work in preclinical science, have done a number of trials, overseen a number of experiments, and is currently leading the team at Ocular for the work. And then we also have Dr. Eric Vatoa, who is the Chief Medical Officer at Active Biotech, a very innovative company that's located in Sweden. Dr. Eric Vatoa has been leading a number of clinical trial studies looking at compound that can be delivered both topical as well as orally. So we are very, very grateful to have our three of you along with our panelists here for this panelist. So Stephen, please go ahead with your first question to any of our colleagues.
Great, thanks so much, Kwon. So, I think that one of the things that we'd love to discuss, at least at a high level, is, as we're all well aware in this meeting, there's several promising retinal therapeutics over the last several years that have been sidelined by inflammation. So we think of abicipar, brolucizumab, ADVM-022, drugs that we're planning to give, I would say, to the masses to treat drugs in diseases like AMD and RVO and others. As we're thinking about therapeutics that have now essentially not being used, in some cases never even launched, is there hope that novel anti-inflammatory therapeutics can allow patients access to these medications, combination therapeutics, or otherwise?
Sumit, why don't we start with you, Sumit? You've been seeing both clinical trial in uveitis and in retina, and we've seen some of the challenges the retina trial facing because In the past, our colleague may not have paid so much attention to inflammation, but now they realize that we've been correct all along the way. The inflammation is extremely important. So what do you think? Some of the new developments in the drugs here that have been mentioned today, you think any hope for us to control it?
I think we got really fortunate with the drugs that we do have, right? So we got very fortunate with Avastin, Lucentis, and Eylea in that we didn't see inflammation. And it's a really interesting question. Can you give steroids at the time of some of these therapies to prevent some of the concomitant inflammation that we're seeing? And I think for some drugs that may be a viable pathway, but for others, I don't think it will be. So I think it's going to be case-based. So for something where we have good alternative therapies, I don't think I see us ever using those drugs. So like for brolucizumab, we have such good options that are alternatives that don't have an inflammatory side effect. I don't see that happening. Whereas for things like gene therapy, I think controlling the initial inflammatory response to the viral vector can allow us to then potentially use those therapies. So yes, I think there's a role. I think it's figuring out A, the dosage of the viral vector, and B, how to control the inflammatory response to that viral vector that's going to be important.
Michelle, Kriya has been working perhaps on some of this aspect here. What are your thoughts, and listen to the way we control inflammation, what are your thoughts of how you may advise Kriya and other team to consider this factor?
Yeah, I mean, I think it's incredibly important. We've seen how inflammation can definitely influence outcomes in gene therapy trials. I think that Kriya is putting that at the forefront of consideration. So we are very cognizant of how we make the vectors, what serotypes we're using, and then just the manufacturing process to really try to improve impurity profiles to reduce that. But I've been really excited today to hear about some of the applications in controlling that inflammation that could be induced from our viral vectors. And I'm definitely going to take some of this back to my team in terms of thinking about our trials. I'm very happy to hear that there is a potential that we can use steroids initially to try to prevent that initial inflammation to the viral vector itself, and then taper and wean as that tapers down.
Great. And Eric, from Active Biotech, you've been looking at things that can be delivered both topical and systemic. And certainly you appear, a number of our colleagues have been talking about advantages and disadvantages of both. So what do you think from this perspective so far? Do you feel like intraocular inflammation, especially that involved in the posterior segment, can be controlled by topical medication, for example?
Oh, thank you, Kwan, for the question. Of course, first of all, we see that well, for our compound, we have a long history of investigating lacuinimod in other systemic inflammatory disorders, autoinflammatory diseases, and we see a clear positive effect on inflammation. And now we have a new formulation, which at least in the preclinical studies have shown to be able to penetrate into the posterior part of the rabbit eye. And of course, this needs to be investigated, whether this holds true also in the clinic. And that's the next step for us to do this dose escalation study in the clinic with the topical formulation.
And if
but I think
thank you, Eric. And then finally, from your perspective at Tubulit, which also moving forward in a number of innovative way too, what do you think this question that Stephen asked in here, is there a thing that perhaps your group can be considered for future control of inflammation?
Well, yes. I mean, I certainly think a wonderful theme coming out of this wonderful conference is there's a lot of promise of anti-inflammatory agents to address all the different aspects of both the disease as well as the aftermath of some of the side effects of certain therapeutic approaches. And I think, but at the same time, there's a lot of complexity, right? I think that's a theme that came up over and over again. You have to tailor it to individual patients, tailor it to the particular disease aspects and what happens. And so I think there's a tremendous opportunity here. Our company, we are focused on modulating various cytokines. We're an immunology-focused company. We're focusing particularly on IL-6 and the potential for offering benefits in patients. But I think a key thing here is really thinking carefully about what is going on in an individual patient and in a particular disease situation, and then tailoring it appropriately. And I think there's a lot of work ahead, a lot of promise, exciting times.
And one other thing I guess that I'd add is, as someone, I'm also involved in biotech, was I've talked to investors, right? So at the end of the day, this meeting is all about innovation and how do we get better therapeutics for our patients. And a huge part of that is investors, right? It's being able as companies to go out and raise the money that's required to actually execute on both the preclinical development, but certainly also then clinical development programs, which are costly and time consuming. Right, Dr. Dacey, Dr. Player gave nice overviews of some of the clinical scope. And so I think one of the challenges in the field right now is that from an investor standpoint, investors are scared about investing in therapeutics that otherwise they might go after because of ADVM-022, because of brolucizumab. And I know KSI 501, right, they're looking at an IL-6 and anti-VEGF, so a combination therapy. So I'm excited to see if we have any non-steroidal anti-inflammatory strategies that could potentially be partnered with some of these therapeutics. Dr. Dacey, Dr. Player, any insight onto the promise of maybe some non-steroidal approaches?
I think we are lucky that we do have now a number of possibilities to treat our patients, and I think it is not so easy, since I have shown that we have different entities, and many of these studies have the problem that we have first studies on an umbrella on different indications, and the endpoint, as I mentioned before, are probably different in different diseases. But still, we do know, for example, in GIA, we have a good response in these children which have been going blind very frequently now. So I think we do have already made a step forward in the last 10, 15 years in the right direction. And we do know that we do have a good response when we target specific cytokines, and we are now on the IL-17 pathway. I'm not so sure whether all these individual cytokines are for the individual patients the right one. So I think we have to have a bit more background on the genetics of the patients. That's this one point. First. Second, we have to have more biomarkers probably that we can, and we don't do so far, take out of the eye. I mean, we monitor just the features that we see in the eye, but these are secondary. We don't see the immediate response probably by downregulating the immune system. So to have more biomarkers which can be taken by blood would be ideal. But we do a lot of taps in patients, and we have a large insight, I think, now on the cytokine networks that is existing in the eye. And probably if we would have better measurements and better indirect measurements, that we don't have to be too invasive in the patient, this would be another step in the right direction to have a more precise, targeted treatment and a better outcome still in our patients. So genetics, biomarkers, and probably innovative agents. These are the three pillars of our future.
So I think it's really interesting. I think we have to think about what causes that initial immune response to the viral antigen, so to AAV. I mean, there's two, right? So there's the antibody response and there's a complement response that happens too. So something interesting that hasn't been looked at is that C3 actually plays a huge role in the initial response to the viral capsid. And maybe blocking C3 as a combination therapy when you're giving a viral vector-based therapy could be really interesting, because it's the C3A that's then released by C3 convertase that brings in the cytotoxic T cells. So, we haven't looked at this, but that's a potential alternative non-steroidal that we could consider.
So my insight was more for the uveitis patients, I have to say. So maybe there was some misunderstanding. But if it is a vector, and if you deliver the gene via adenoviruses, I'm not sure. I mean, about 20% of the patients have antibodies against the virus. Yeah. Is there any kind of vaccination an option? I mean, do you check the patient before? Do you have probably to have more insight what the patient already brings in regarding the immune response directed against the virus? I mean, just the simple idea. Is vaccination a kind of option so that we don't have an immune response?
I would say that we do pre-screen patients to look for whether they have NAbs, which are neutralizing antibodies to the capsids, or whether they have just tabs, which are total antibodies. We stratify patients in terms of who can enroll initially based off of that feedback, so that we are trying to get seronegative individuals to enroll first. But I do think that these are all considerations that we have to continue to try to expand on as we want to treat broader populations and not exclude patients that might have pre-existing immunity.
That's certainly a very, very good point there about the screening thing and trials. So Mark, what do you think? You think that is something plausible to do? Michelle and others has raised a point there because of the presence of, let's say, neutralizing antibody and type of on there. Would that be something that we advise when we consider trial, let's say in clinical trial in retina next time, that in order to best decrease this opportunity, that we can consider pre-screening the patient with that, and whether or not the probe is actually sensitive enough to. Mark or any colleague there would like to share? Go ahead.
Yeah, I think those are all reasonable things to consider. We're kind of going into uncharted territory here, right? These are studies that we haven't looked at before, but I think those are all reasonable ideas to try and mitigate the amount of patients that would be potentially non-responders.
So Sumit, why do you think then, if that's the case, why would other group would not do just pre-screening ahead of time?
So I think it's a challenge in terms of clinical trial enrollment, but there's been a number of attempts at reducing the amount of antibodies against the drug, right? So you can change the capsid, you can try to hide the antigenic features on the capsid, but every time you say, okay, we're going to limit and we're going to make it smaller and smaller, your potential enrollment pool for the study drops too. So it's a balance. You have to balance the risk of inflammation. And I don't think we've had until recently, so with Verum and a couple others now, we haven't really seen the inflammation, but now that we've seen it, we know that it has to be controlled. And so I think going forward, we will be doing more of that screening and trying to take out the patients that are more likely to have an inflammatory response. The problem is then when you go live and you submit to the FDA, you limit your patient pool if you use that as a requirement for enrollment in the study. So then it becomes any patient who's going to get treated with this has to have that testing, and if they have antibodies, you can't treat them in the future. So there's a number of reasons why.
Yeah, and I would just following up on that, I think that when we're thinking about the general retina patient pool, it's hard to screen when you think of just the sheer volume of patients, for example, that have DME, right? AMD, DME, and maybe even especially DME, right? Where you some patients in resource poor areas that are just coming in and getting shots. So screening everyone is challenging. I think that's where, novel approaches like maybe a C3 inhibition, Sumit, like you had mentioned, that could be something that's what I think ultimately the field wants, but we just don't have that yet. Right. And I think that meetings like this hopefully give, world-class uveitis specialists like everyone here on this panel, the opportunity to work with industry on coming up with potential pathways to address this issue.
So Young, you mentioned that Turbulent is looking at IL-6, and then throughout the whole conference since this morning, a lot of data has been shown the role of IL-6 in here. And now when many of the trial, when they try to consider vector therapy or gene therapy, they just suppress the patient, somebody with corticosteroid, systemic corticosteroid, which has obviously a lot of side effects as well. Would you think that something like that still have proven to be quite powerful at an IL-6 inhibitor? Would that be something that one should consider? Because right now, for whatever reason, maybe there's insufficient amount of knowledge or data that people just say, oh, to suppress the inflammation, just put patient on topical and a lot of time nowadays oral prednisone. Would that change if we show more role for IL-6? Inhibition?
Well, I think the reality is, I think initially, right, over the past few decades, initially has been thought of inflammation as this general, non-specific phenomenon. But I think over the years, there's been a lot of great insights informed by actual human data that it's very much like multiple different processes. The inflammation is not just one size fits all or one type of process. There are many different types of processes. And so I think it really comes down to, for both at the disease level as well as individual patient level, what is the exact nature of the processes that are going on. And so that's an exciting time to interrogate this type of new biology. And I think for IL-6, there's actually been a renaissance in recent years. I mean, I think IL-6 is a drug target that's been well established and known about for decades now. But I think in the past few years, there's just been a surge of new insights. And part of it, it relates to the fact that you have to approve products, right? And so there's a lot of hypothesis generating clinical observations that are used from just real world practice that people have tried. And it's hypothesis generating, but still informative, right? And then there's also a lot of biomarker data that's emerged related to IL-6 and other inflammatory pathways. And then finally, it's an unfortunate, very tragic natural experiment that's happened over the past few years of COVID-19, right? COVID-19 is it induces inflammation and certain types of inflammation. And fortunately, that's led to a lot of suffering, obviously. But it also provides, though, insights into the types of biologies that may be informed by such things that are triggered by COVID-19 infections, such as IL-6 and other cytokine pathways. So turning it back, I think taking advantage of all this new insight to really think through, like, where could, say, for example, IL-6 directed approach or other cytokines have the opportunity to have impact? I think, yes, there is an opportunity to investigate these hypotheses.
And then, Eric, your group with laquinimod approaches a completely different way. Now you try to control in terms of the antigen presenting cell, which is a different approach here, which was really relevant to this. How do you think, let's say, laquinimod, whether publicly or already move forward, how do you think it can play a role in controlling inflammation, whether directly for uveitic entity or in conjunction with some of the other retinal therapy that use vector or gene therapy as a way to deliver the product?
Well, we see with laquinimod, we see that induces immune tolerance, shifting the T cell response to more immune tolerance profile. So of course, the preclinical data that we have is from autoimmune uveitis models in rats, but it's not. So we need to do those experiments in the preclinic to find a suitable model for investigating laquinimod also in this post intravitreal injection inflammation. So that's a question that needs to be answered, of course.
That's great. Stephen, any other questions from you? Anything else?
Well, I think that I know we need to wrap it up here soon because we're a little bit over time, but we have industry and we have leading clinicians and researchers. And so just kind of very briefly, maybe starting with industry, what are things that on the industry side we can do to help our retina specialists, uveitis specialists enroll clinical trials? And then obviously we've already had some talks on this, but maybe, Dr. Dacey, Dr. Player, you could just give some insights on what you think industry could do to help you find patients and enroll patients in your trials.
Go ahead, Mark, and then Sumit as well.
So
Michelle, do you want to go ahead?
Sorry, go ahead.
Sorry. Yeah, I think that one thing that we in industry are doing are trying to find centers of excellence that we work with, and we begin those relationships very early on, particularly even in the preclinical setting where we can get feedback on recommendations, suggestions on how we might handle inflammation and really try to apply that early on so that we're increasing the learnings. And then I think really leveraging the feedback from the clinicians on what patients will tolerate. I think it was really interesting to hear today that steroid treatment is something that patients are like, no. In some indications that we just have to be thoughtful about. And so I think as early as possible, starting to work with centers of excellence and getting that feedback so that we can incorporate it into our development plan is important.
John?
Oh, sure. So, I mean, I think, I think it really is a partnership, as you are alluding to, and really to we're all in this together to make a difference for patients suffering from diseases. And I think one of the things actually would be very helpful for industry is, as we think about designing clinical trials and drug development paths, there's a lot of decisions that have to be made, and they're not straightforward, right? You can think about essentially 3 dimensions that one has to think through about the optimal trial design. So first is, you really want to ensure the rigor of the study to make this as robust a scientific test of the hypothesis as possible. Number 2, you want to obtain meaningful information that's relevant to how patients are impacted by disease, as well as how they're cared for in the real world, right? And third, the practical and real world aspects of this. And sometimes all 3 dimensions, that you can't get all 3, right? You have to make some difficult trade-off decisions. And so I think getting insights from our academic colleagues as we think through these important considerations is really valuable, really helps us think through how to approach this, right? And I think just today, the excellent talks from Dr. Dacey and Dr. Player about inclusion-exclusion criteria consideration, endpoint consideration, very, very helpful insights. So I think more of that would be much appreciated for us.
Eric?
Yeah, I completely agree with the panelists here before me. I'd also like to bring out the patient advocacy groups and the work we can do with them already ahead of starting a trial, discussing the trial inclusion criteria, the kind of the benefit for patients for coming new treatment option. So I think that's an important part as well of the discussion.
So from the clinic perspective, I think the collaboration on the front end, as Young and Michelle alluded to, is so vital, because ultimately we have to be able to find patients who are going to be able to enroll in these studies. You can have a perfect study design, and if you have 10 patients a year in, we go, okay, well, maybe this wasn't maybe the best of collaborations. So the more of that we can do on the front end to try and mitigate all these factors, I think is crucial. In the clinic, in terms of the clinic, I think one of the things we always struggle with is identifying patients, and I almost need like a neon sign blinking in front of me all the time to remind me to look for patients. But a lot of it is the philosophy within clinic. So Charlie Wyckoff down in Texas once said, every patient is a research patient until proven otherwise. And that's a philosophy that we've really tried to take to heart, where you're trying to pre-screen clinic. You'll have research techs, or you'll have your own clinical techs looking through your schedule in advance, trying to figure out, okay, that patient might work for this study, this patient might work for this study. And if you're at least thinking about it, then you've got a much better chance of doing it. If you're just trying to get through 40 or 50 or 60 or whatever patients, you're never even going to think about research. Excuse me. And so I think having that out in front as much as possible, and little simple things, and this is going to sound crazy, but I put little laminated cards about this big on the bottom of my computer with the studies that are currently enrolling with basic inclusion and exclusion criteria. And sometimes that's simple enough to just make the light bulb go off and go, oh, okay, maybe this might be a patient who could enroll here. So those are some of the challenges on the clinic side, to try and identify these patients, because they're difficult and the studies take a while to enroll. So you have to take this many patients to be able to cull down to a few that might be able to enroll in the studies.
Awesome. Thanks, Mark. Dr. Player?
Yeah, I think in Germany, at least, we have the burden that we have too many patients, actually, I have to say. So it sounds very good, since you have a lot of patients that you can include. But on the other hand, you're so busy with your daily clinical work that it's not so easy to have, let's say, good studies and good recruitment. And the other problem, which is also probably more in Europe, I would think now, than in the States, that the bureaucracy is really overwhelming. And you have to have a backup even for the photographer. You have a backup for the technician who keeps the medication. And I need a team of 12 persons at least to have one single patient recruited. And this gives a grim picture probably from the inside, but I have to say it's really a struggle to have patients recruited. We don't have problems to recruit since we have a lot of patients, but you have to devote a lot of time. You have to individualize the requirements for each of the patients. And these are young patients. These are active. These are in their profession. They are really not having time for, let's say, 3 times a week controls. So you have to have really a selected and very well constructed protocols that you can really offer somebody who is active in life. And these are a lot of requirements which in the daily practice are making studies difficult. We like to do studies. I have to say we are really happy that we have so many options now and that we probably have in the future a more targeted treatment for these patients. But again, I have to say I can compare with, say, let's say 30 years ago. We even did an investigator-driven trials. I mean, before we did studies which have been not controlled by the industry as they are doing now. And this has been really targeted only to the industry, which is, of course, a good partnership. On the other hand, before we had more freedom to do studies like on cyclosporine, even before it was in Germany really proven as a treatment for posterior uveitis. We did this, or mycophenolate mofetil, which never has been approved, but still is as a well-organized off-label treatment. And I have to say, many of our patients are now on off-label treatment. So we don't have the access to a lot of biologicals. Even tocilizumab is not approved for uveitis in Germany. And we are using a lot of these agents now, and we have for each single patient to require an off-label use. And this is another, let's say, burden for the residents and for all people involved. So I think we have to make the things more slim, more targeted. And of course, we are very happy to participate in clinical studies which are promising.
Thanks, Dr. Player. And finally, Dr. Sharma, what are your thoughts?
Yeah, I think, one of the things that we don't often take into consideration that uveitis isn't one disease. It's a heterogeneous mix of many different diseases. And as we get into some of these more targeted therapies, it's going to be important to really hone in on who are the right patients to enroll to give you the best chances of success for your trial. Like if you're an anti-IL-6 study, maybe enrolling patients who have macular edema should be a requirement because they're going to be more likely to be responsive to it because macular edema is often IL-6 driven. However, on the flip side of it is we don't know the cytokine expression profiling for a lot of these diseases. So some of the things that have been being done recently include taking either anterior chamber or even sometimes vitreous taps in order to get the cytokine profile and see what's happening in these patients. And so I think going forward, really trying to remember that it's not one disease, uveitis, it's many different, and targeting the trials based on the molecule's mechanism of action will be important. I know that limits the patient population, and I know that often is a challenge already with to enroll studies, but remembering that will be important from the industry side. But I think early collaboration so we can help identify the right patients and the right study design is critical. And I think we're seeing more and more of that. So like Dr. Dacey said, getting rid of the prednisone initial burst, it has been very helpful for a lot of the studies and enrollment because there's tons of patients who hate that. So things like that and continuing to work together is important.
Wonderful. Well, I want to say a special thanks to everyone. This is going to conclude our session today. I know we've gone a little bit over time, but every minute's been well spent. And thanks to everyone who's joined for this meeting. Special thanks to our faculty. This isn't a meeting without each of your expertise, and the time that you volunteered to share with us means a lot. So thank you so much. Everyone, in terms of attendees, you're going to receive emailed instructions on how to obtain CME credits. I also want to thank our sponsors. Again, this meeting doesn't happen if we don't have our sponsors: Alcon, Apellis, Bausch & Lomb, BI, Genentech, Iveric Bio, Regeneron, Resolute Bio, and Tourmaline. Thank you to each of you for sponsoring and making this possible. And then finally, before you go, we have a really special meeting planned for November 2nd in San Francisco. So similar format to today, except that it's going to be live in person the day before, the afternoon before the American Academy of Ophthalmology meeting. So please mark that on your calendars, register today. Plan to show up to San Francisco a day earlier than you otherwise would to join us in person. And again, thank you so much. I hope you have a great rest of your weekend, everyone. Bye now.
Thank you.
Thank you, everyone.
Thank you.
Great. Mark, thank you. And Sumit, thank you very much for joining us. And Dr. Plyer, thank you for joining us late from Germany as well. Thank you.
Yes.
We really